traffic in Brussels, we are going to start a bit later, probably at 10 p.m., but we are going to wait for the people to arrive and let them a chance to be here from the beginning. So sorry about that. You can also have coffee on the first floor. I think you still have 5 minutes to go grab something. Ah, ok.
Should we get started? Yes? Great. Good morning, ladies and gentlemen, professors, doctors. Thank you all for joining the EU4H, sorry, this is going to come for the day. It will be perfect afterwards. EU4Health Integration and Impact Initiative, a joint program of several organizations aiming to address major public health challenges in various fields of healthcare. Sandra Galina, Director General for Health and Food Safety at the EU Commission, will introduce the symposium. As she couldn't be physically present today, she recorded a video message on the importance of such a project for the Union. Let's listen and watch her.
Ladies and gentlemen, I am really delighted to send you this message today for a forum that has gathered so many experts. All the topics on the agenda are vital for the European Health Union, so our work will be helped by your work to improve people's health across Europe. Let me try to provide you with an EU perspective on the topics that you will be discussing today. First of all, One Health. Now, this approach highlights the interdependence of human, animal and environmental health. Traditionally, it has focused on antimicrobial resistance and zoonosis. But One Health is really much more, and it is more relevant for non-communicable diseases like cancer, cardiovascular disease, or for instance, diabetes. We know that environmental factors impact human health. We have seen that even so often. For example, the relationship between air pollution and respiratory diseases is one that is very well established. I would also say that taking a comprehensive lifelong prevention approach in line with One Health can lead to more effective health outcomes. Now, the Commission continues to support all the EU governments in the Member States in trying to reduce the burden of non-communicable diseases. This is a mammoth task, as you can imagine. It's all guided by this Healthier Together initiative that we adopted in June 2022. One of our latest measures on prevention is a recommendation on vaccine-preventable cancers that was adopted just in June by the Council this year. This recommendation is actually designed to help countries increase vaccination rates against human papilloma viruses and hepatitis B, both major contributors for cancer. Now, in September, the Commission proposed an update to the recommendation of smoke-free environments. This, again, will help countries protect people from second-hand smoke. All these measures exemplify a One Health approach. Now, you have a second topic which is interesting, and it's brain health. Brain disorders are a leading cause of disability in Europe, unfortunately. They put a very, very heavy burden on patients, families, health systems, and they are a huge unmet medical need. I already mentioned the EU's initiative on non-communicable diseases, Healthier Together, but I would like now to mention to you that one of the main strands is mental health and neurological disorders. Now, the Commission adopted a comprehensive approach to mental health in June last year, and it put mental health on a par with physical health. This was very, very important. Now, one of the flagships is the so-called Joint Ecosystem for Brain Research. This supports coordination to maximize the impact of EU and member state research investment. Fragmentation is never good. A European partnership on brain health is due to start on 2020 in 2026, and the coordination and support of the Action Brain Health is laying the groundwork for that. In addition, the thematic network towards an EU coordination plan for brain was launched by stakeholders on the EU's online health policy platform. Now, it helps unite the brain community to develop policy recommendations for European brain health research and innovation. The final topic, and third one, is childhood cancer. For 14,000 children and young people in Europe, there was a cancer diagnosis in 2022. Tragically, 2,000 of the lives were taken last year. The hopeful news is that the vast majority of children survive cancer, but the journey does not end there. Cancer and its aftermath leave lasting marks, unfortunately, on survivors and their loved ones. The Europe Beatings Cancer Plan is the EU's tangible commitment to turn the tide against cancer. It includes a flagship initiative called Helping Children with Cancer. I'm proud of the valuable projects resulting from this initiative. The European Network of Youth Cancer Survivors has created also a virtual platform where young people can connect, share their stories, and find reliable information. There is also a platform for young cancer survivors as part of our comprehensive approach to mental health, which is an important thing. Finally, I would like to mention the European Reference Network for Paediatric Oncology, a very important network. This cross-border network connects European expertise and aims to make specialized oncology treatments accessible to children across Europe. It is committed to reducing inequalities in survival rates for childhood cancer. I would like to close by saying that there is so much important work happening on non-communicable diseases, brain health, childhood cancer, and these topics also feature in the plans for the next Commission mandate. Today's forum, your forum, can be a catalyst for action. You can bring people together. So I encourage you to make connections not only within your area, but across all the three topics. Together, you can help improve the health of Europeans, but also help us in build the European Union. Thank you.
And to further explain the genesis of this main event of the initiative, I will hand over in a few seconds to Professor Michelle Goldman. Michelle was in charge of the overall organization of this symposium, together with someone that you do not see here. She's at the first row. She's Caroline Van Swieten. She did a great job, an amazing job. And also together, she did it together, of course, with the other partners of the consortium. I won't tell all the names, but you will see that was a huge organization and investment. So Michel Goldman is a medical doctor specialized in clinical immunology. He was the executive director of the European Innovative Medicine Initiative before founding the Institute for Interdisciplinarity Innovation in Healthcare, I3H, from the Université Libre de Bruxelles. He's the author of more than 450 publications and is also the recipient of several awards, including the prestigious Blaise Pascal Medal in Medicine and Life Sciences received this year for his long-standing commitment to advancing scientific knowledge and fostering interdisciplinarity and public-private partnership. Michel Goldman is also the editor-in-chief of Frontiers in Medicine, which is a sponsor of this event. Please welcome Professor Michel Goldman. So, Professor Goldman, could you tell us why the I3H Institute has been involved in this initiative? And I will leave you the floor.
Let me first tell you how proud, happy we are to be the coordinators of this EU4Health Integration and Impact Initiative. I think that Sandra Gallina clearly explained how important this type of initiative is for the European Commission, for the European Union. And it's true that with our team led by Caroline Van Swieten, this has been really a unique experience because we had to bridge competencies and also expertise from different fields. And I hope that at the end of the day, you will understand that bringing together people from different horizons indeed is extremely fruitful to move healthcare forward. So a few words about the I3H Institute, the Institute for Interdisciplinary Innovation in Healthcare, which was created 10 years ago at the Université Libre de Bruxelles, with the objective to attract scientists who come from various disciplines and who aim to build the future of healthcare. For this purpose, we first established a unique interdisciplinary and inter-university educational program, which is led by Professor Hilde Stevens, who is with us today. The students attending this course come from various horizons, from various disciplines, not only biomedical sciences, but also public health, informatics, economics, law, and ethics. What they have in common is a keen interest in healthcare and a willingness to work as team players. The courses are given by international experts from academia, industries, and non-governmental organizations who share their personal experience to illustrate the need to bridge various competencies across disciplines and also across sectors, public and private. And this is to build again the future of healthcare. Later on, the I3H Institute developed a series of research activities with a special focus on various economical aspects after we were joined by Professor Mathias de Watripon, an internationally renowned economist. As examples, these are just examples, we analyzed the roots of the opioid crisis, the multiple challenges related to rare diseases, and drug repurposing. During the COVID-19 pandemic, we have been quite active in making a series of recommendations to policy makers, and actually Mathias de Watripon was an advisor to the Belgian government for this. Very recently, Mathias, together with other top-notch economists, actively supported the report of Mario Draghi, which strongly argues for massive investment in Europe for research and innovation. And this is, of course, very relevant to our conference today. And perhaps you heard that a few days ago, the President of the Commission, Ursula von der Leyen, again emphasized that science-based innovation should be the cornerstone of the European Union. In this context, it was quite natural for us to apply to this competitive call of the Commission, which aimed at contributing to the development and implementation of the health agenda of the European Union for the years to come. Together with our partners, the One Sustainable Health for All Foundation, the European Brain Council, and Childhood Cancer International, we decided to address three main topics which were already mentioned by the Director General of DG Santé. Firstly, the One Health concept, secondly, the multiple impacts of brain health, and thirdly, the need to prioritize the quality of life of children who survived pediatric cancer. The connections between these topics will be emphasized during this conference, which is very much in line with our vision to promote interdisciplinary approach to move healthcare innovation forward. With this symposium, but also additional events and through multiple communication channels, All of this being coordinated by my collaborator, Caroline Van Swieten, who was already mentioned. Our key objective is to raise awareness on those three major topics among EU citizens, patients' organizations, and other stakeholders, including policymakers and healthcare professionals. Our hope is that this initiative will reinforce the current efforts of our partner to prioritize One Health, brain health, and childhood cancer at the top of the policy agenda currently elaborated by the new European Commission. Thank you very much for your attention.
Thank you, Michel. Benoît Miribel is the Secretary General of the One Sustainable Health for All Foundation, which was launched at COVID 2020 conference. He coordinates the One Europe for Global Health Coalition. Prior to that, he was the CEO of Fondation Mérieux, an organization dedicated to fighting infectious diseases in developing countries. He is the co-founder of the bilingual journal Humanitarian Alternatives and is a member of the think tank Global Health 2030. Ladies and gentlemen, please welcome Benoît Miribel. Bonjour.
Bonjour.
Benoît Miribel, One Health is going to be the first topic to be addressed today, and I leave the floor to you.
Thank you very much. Thank you all. Thank you to the team, Michel Goldman, Caroline, and all the organizers for the welcome. Yes, this topics, by the way, is linked, of course, to the others, as we know, because everything is somehow linked in our world now. For this introduction, will be not to discuss in the details what is about One Health, because I think that you know that. But what we are doing and what we started to do during the lockdown. So I have a few slides to show you. Yes, this is the second one. Maybe we can see the first one. So what we do, and this comes from commitments from various experts, scientists. We were discussing during the pandemic. We were at home and wondering about the silos. Everyone knows that, but the question is how to make a progress with respect to the verticality. We need all disciplines, but we need horizontal approach. We were discussing about that. And so I was at the time the chairman of the French Foundation Center, and I've asked the support of several foundations, and they agreed to give the possibility to experts to discuss aside from their main activity. You see what I mean? You know, working in these corridors, specific corridors. So somehow what we have done since that time, it's capacity to strengthen the civil society engagement in One Sustainable Health. So the One Sustainable Health was defined by the scientific panel as a junction between One Health approach, which is not new, and the SDGs, you know, the Sustainable Development Goals. So this is why we have this approach. It's not. It's just a way of considering what is One Health with planetary health, with the SDGs, and it is somehow what we call One Sustainable Health in this civil society commitment. And of course, it starts from the quadripartite redefinition of the One Health. So step by step, we have more and more organizations joining this initiative, and we have also experts. So we had, during the first 2 years, 6 international working groups, and you see some profile of the Scientific Council. So we are international, and there is Antoine Flao, for example. He was one of the expert committee that at the beginning, and we are still, of course, in partnership with Geneva Health Forum that he founded, and with the World Health Summit in Berlin also. And so year after year, we were moving, And we were able to publish this result, recommendation coming from the 6 international working groups. And also, at the occasion of the EU presidency, France EU presidency, we were working on a paper, Building European Health Union. And I was at the same time, I'm a member of our, in France, National Council, Economic, Social, Environmental, and I was doing a report, you can find it, it's an official report on how to build European Health Union. We know that Europe was built for steel and coal, and that with the Green Deal, we did also with health issues to reinforce this component. So thanks to the commitment of the team and the partners, you see that we were invited after Lyon when we started this, every 6 months in different places, and we were a few days ago in Budapest under the Hungary presidency of the EU at the academic science. So I'm reaching the end. Just to share with you this new biennium in which we are now, with 9 international working groups. We may have another one about, an additional one about one digital health. We had a meeting about that at the French embassy in Berlin 1 month ago. And we also work, and when I say we work, it comes from the experts and the organization, you know, about a kind of OSH institutes. So it comes from several regions in the world. We had an official workshop on that, about that in Berlin. We will have a roundtable at the new WHO Academy that will be inaugurated on December 17 by Emmanuel Macron. So a few days before, at the WHO Academy, we will discuss that. So we are not going to build, a new building for an institute. No, it's, based on the existing institute in Europe, in America, where we need to do the link between transdisciplinary and multi-stakeholders, which is not easy, with different kind of civil society components for discussion. So this is my last slide, inviting you to attend or to follow the next, we have an annual conference about that, and it will be in Lyon, early July. We had one last year. We were invited by Awa Marie Kolsek, the former state health minister, to go to Dakar. So we were in Dakar in October, as you see. So which is why we are international, because we are all facing health, environmental, and social challenges. We work a lot on the social in order to make sure that what we expect is possible. We have now again to face the strike in France from, the peasant agriculture because due to the regulations. So on one side, if we go too fast, without the civil society understanding of what is at stake, it costs a lot of money and energy. So thank you all, and we are here with the team, with Brian, Casimiro, and also Klaus Sorensen. So we are here to answer. You're welcome. It's an inclusive forum. Thank you for you.
Many thanks. Delphine Hennen is the managing director and founder of the Belgian foundation Kick Cancer, the mission of which is to develop more efficient and less toxic treatments for children with cancer. It is actually the lack of innovative treatments offered to her son, Raphael, that drove her family to found Kick Cancer. Delphine Hennen is also a committee member of Childhood Cancer International Europe. Delphine, please join us on stage. So, being part of the EU4Health initiative was crucial for Kick Cancer. You are going to give us an overall picture, actually, of what survivors of pediatric cancers have to cope with.
Thank you very much, Vanessa, for this very kind introduction. I really want to start my speech by saying that Childhood Cancer International, which I represent today, is really delighted to participate in this conference under the EU4Health program. Creating a supportive environment for cancer survivors requires to break silos. And this conference is a really interesting and wonderful first step in this direction. So thank you to the organizers, Michel, Caroline, and to the participants to include us in this very important discussion. So I am the mother of 4 boys, one of which was diagnosed with cancer in 2013. And it's when he relapsed in 2016 that the idea, started growing in my mind to contribute to political question of health, and especially in the field of pediatric cancer. My son passed away 3 months ago, so apologies if my voice trembles, but it's recent and I'm still quite emotional on this. But I can take distance with what happened to me and really have a theoretical framework view on the topic. So first things first, going back to the framework, I would like to give you some context on pediatric cancer and why collaboration and silos are really 2 important themes in the work that we do. Every type of pediatric cancer is classified as a rare disease under the European definition of rare diseases. We don't have the same numbers as Mrs. Galina, but it's because we're looking at the European continent and not just at the European Union, but in Europe, breaking silos, 35,000 new cases of pediatric cancer are diagnosed every year, from the age 0 to 23 included. Tragically, today, 20% of the children and young patients succumb to the disease annually. That's 6,000 people a year dying from cancer. It remains the first cause of death by disease for children over 1 year of age in Europe. In a developed country still, of course, it's even worse in countries where there is no access to the basics of medical treatments. Today, in Europe, there is 500,000 survivors, which is a great success. This number continues to grow. And while we, as Kick Cancer, fund research specifically because we want to cure every child with cancer, we cannot take out of the picture that we want every child surviving from cancer to thrive after their treatment. And we're far from that today. 2/3 of patients are considered as suffering from long-term side effects caused by their treatment or by the disease itself. And that number is according to scientific research conducted on the topic of long-term side effects. You will see that if you ask patients the same question, are they free from long-term side effects? I think that the figure of 2/3 of the patients will significantly increase. Actually, there are some first papers coming out on the topic, and we are closer to maybe not 100%, but 95% of the patients. Still, for many of these patients, the tangible impact of the side effects will be felt in their day-to-day life. So what are these common side effects? Amputations in one of them, and that's one of the side effects that my son suffered. Neuropsychological late effects, such as learning difficulties affecting thinking, learning, memory. Organ removals is also something very common in the framework of treatment for children with cancer. Social and psychosocial adjustments, often leading to post-traumatic stress disorders, secondary cancers, and shorter lives. Endocrine disorders, impaired growth and development, physical asymmetry, which can affect survivors physically, leading to pain, but psychologically, leading to isolation. Weight issues, and there are many more that I'm not going to name here, but definitely chronic diseases, coronary diseases, heart failures, diabetes are among them. Many of these long-term side effects take a heavy toll on survivors' mental health, well-being, and confidence. They can also affect their ability to integrate into society and pursue emotional and professional lives. So why is it so crucial to address long-term side effects? Well, survivors must be equipped to adopt healthy habits following their treatments. The scope and the impact of the long-term side effects will be lightened if they have a better lifestyle, if they are well followed up by our systems. So they need access to well-organized follow-up care. It's crucial. And what are the factors that do exacerbate long-term side effects? The age at cancer and the gender of the patient, the type of cancer, including its developmental stage, and the treatments administered. But also, and that's not to be underestimated, socioeconomic status of the patient and the region where they live has a huge impact on the width of the long-term side effect that patient will suffer from. And this latest remark creates a direct link between general survivorship concerns and the one sustainable health approach promoted by today's first guest. There is a huge political dimension to survivorship care. There are disparities across Europe, education of the patients, the ability to invest in the young patient's recovery significantly influences the future of their quality of life. The level of healthcare professionals training itself on this topic also varies across countries. So we see that certain countries have a great follow-up clinic, some don't. And the impact is really gruesome, between the patients. The cultural attitude to healthcare also has a huge impact on the quality of survivorship. And there is a stark contrast between regions where there are approaches prioritizing prevention with others prioritizing interventions, and prevention naturally leads to much better quality of life for patients. So there is a need for a holistic multidisciplinary approach. Survivorship care must bridge a lot of different disciplines and age group. For instance, one aspect that can be often underlooked is the transition from pediatric care to adult care. And one should not underestimate the complexity and difficulty of this. There are so many aspects that are not typically taken into account. How we speak to the patients in pediatrics versus adult care. How we involve the family in the care of the patients between pediatrics and adult care. These concepts are very complex and require multidisciplinary thinking. So European collaboration is essential. The rarity of pediatric cancer requires a European-level approach. No single country possesses the scale or expertise to fully comprehend the complex range of survivorship challenges. While follow-up care plans will be, of course, remain implemented at a national or regional level, their design requires collaboration between survivors and healthcare professionals at the European level. Involving patients in how they want to have access to follow-up care is also crucial because it is a huge impact on their day-to-day life. So they must have a voice in shaping the model of follow-up care. So designing a program without understanding their needs is nonsense, and it's futile. Which brings us to another significant component of follow-up care in pediatric cancer, which is a wonderful bridge to the other guest today, which is the Brain Council. There is a significant psychosocial impact of the pediatric cancer. As the session of survivorship will unfold, and it will come last, you will understand with great clarity that mental health and well-being must be an integral part of any survivorship program. Survivors, as I already underlined, often experience post-traumatic stress, anxiety, and loneliness. Less frequently acknowledged, but equally impactful, the psychological toll of pediatric cancer on the close family members. It is not uncommon for parents to struggle emotionally after their child's treatment. Siblings are often also deeply affected by the illness at all levels, at an age where it's not easy for them to understand what is going on. They are often overlooked, and actually it is one of the long-term side effects of cancer. Naturally, we all dream of a future where pediatric cancers will be cured with short, non-toxic treatments that do not disrupt the education, hobbies, and social lives of the young patients. While we work towards improving these treatments, we cannot wait. We cannot wait to also improve and start improving significantly the follow-up care for survivors. This strategy must encompass the diagnostic, the treatment phases, and the survivorship. So how can we better support patients and their families to minimize the potential for trauma and the potential for a better health? I'm really looking forward to the discussions today and to the partnerships that we might create with One Sustainable Health and the Brain Council to make sure that survivorship becomes an easy transition. Thank you very much.
Have you seen these sketches? So there is someone there. He's not typing, actually, what you are saying to the people. He's just designing everything. So this is going to be the story of the day. And his name is Monsieur Lapin, Philippe de Caluet. Do not hesitate to share on social networks. This could be nice, huh? Hashtag Monsieur Lapin or at Monsieur Lapin? Voilà. So you know. Frédéric Destrebec is not going to design anything, but he's going to talk. Can you design maybe? He's the director, the executive director of the European Brain Council since October 2014. The organization is made of several scientific, medical, and patient organizations, as well as industry partners, national brain councils and associations, and other stakeholders. EBC promotes brain research and brain health with the ultimate goal of improving the lives of almost 180 million of Europeans living with brain condition, including both neurological and mental health. So Frédéric, please join me on stage, and I will leave the floor to you with this question: why was it interesting and important for EBC to be part of this initiative?
Thank you very much, Vanessa. And indeed, better not ask me to draw anything this morning, but I'll do my best in sharing with you my quality of presenter. On behalf of EBC, but also primarily on behalf of our president, who sent an apology this morning and was really sorry not to be with us, and I'm on stage on our behalf. As Vanessa was saying, the European Brain Council is a multi-stakeholder platform promoting brain health, brain well-being, brain research, brain innovation, and this notion of the brain capital at a European level, bringing together patient organizations, clinical, professional, and scientific societies, as well as the private sector, and as well as a network of national brain councils. And we have some of their representatives in the room today, and we very much appreciate the collaboration that we have established in that respect. So I don't know if it's... So actually, it's not working. Yep. So why are we here? Why did we create the EBC more than 20 years ago? First and foremost, because of the burden and the impact on society and on individuals of brain disorders, mental and neurological alike. You will see on the upper graph the DALYs projected up to 2050, and underneath the years of life lost. These are data extracted from the IHME, so the Institute for Health Metrics and Evaluation. They are the authors of the Global Burden of Disease study, the most recognized and most advanced epidemiological collection of data. And what it basically demonstrates is what Director General Galina was saying in her introductory speech, that brain disorders altogether are the #1 source of disability in our society and the second cause of mortality. It's obviously a very complex picture, but it definitely prompts a need for action and a need for understanding and addressing these challenges, but also, as we heard from Benoit and from Delphine, the many interconnected implications and consequences that they can have across the healthcare system. But definitely, as we can see also on these graphs, is that the impact and the burden is on the rise, and there is definitely also a worry that this can imbalance or deplete our healthcare system as a whole if nothing is done in order to address this challenge. So the best way to address this challenge is really to make sure that we respond to those needs. Hence, the adoption by BC last year of a pledge for science, because we were advocating for equipping our research community with the best, not only instruments, but also the best environment in order to meet the societal challenges that they would like to address by producing better research and more research in the EU. So basically it relates to funding, it relates to better coordination and collaboration, but it also relates to making sure this environment nurtures curiosity-driven science and academic freedom. And this is what we are trying to defend in the whole of our policy agenda. And particularly in the context of the European elections, we adopted this manifesto under the title No Health Without Brain Health, that basically contains a series of policy recommendations, but two are really those that we would like you to remember today. First is the creation of an intergroup within the European Parliament on brain health and brain research to address in an apolitical platform the needs of the community and some of the elements that I'm sharing with you today. And second is the emergence of an EU coordination strategy that would accompany the development of national brain plans within EU member states. So as you see, we were sharing this manifesto with many candidates. We had the support of more than 120 organizations, but also have been supported by 5 political groups, and we are now very hopeful to see this coming in together. I won't nag you with all the steps and all the milestones of our campaign timeline, but obviously the event of today was a very important landmark in advancing the understanding and the recognition of our priority needs, and we are really grateful to be part of this initiative in order to really provide this understanding of the implications and the collaborative needs in that respect. Just a quick word, because it was mentioned by Mrs. Galina once again, the Brain Health Partnership is going to become a really important step in avoiding and overcoming the fragmentation and duplication of effort within Horizon Europe. So this is going to enter into force in 2026, but you can see with the dates on this graph that this is work being started actually almost 10 years before, with the adoption of a consensus statement by the EBC, where it was calling for such a merging of effort and a centralization of effort within the EU funding instruments. So there is an agenda, a strategic research and innovation agenda that was developed in that respect, with 4 key pillars to promote brain health, having and achieving a better understanding and optimization of our healthcare systems, achieving a better understanding of the condition for early diagnosis, monitoring, and intervention of brain disorders, but also addressing all the societal aspects of brain health as a whole. This agenda was released very recently and is going to now become the cornerstone of the partnership in the future and how it will leverage collaboration between member states and with the European Commission. So obviously, building on that, we are also very hopeful that the Healthier Together initiative, the NCD, so the strategy on non-communicable diseases of the European Commission, addresses mental health and neurological disorders with the right degree of ambition. It's the 5th and the last pillar of the strategy that deserves now the prioritization by the DG Santé, and we are looking forward to the adoption of the key initiatives in that respect to make it happen, but also create the change for people in need in our space. Obviously, I cannot avoid also mentioning what Michel was alluding to, is that now science-based innovation is really the cornerstone of the strategy of the new Commission that was just basically entering into service as we speak. Competitiveness, innovation, skills, and education are all features that we now see as being central in the agenda, also with the drive of the Draghi and the Letta reports. So this is really now creating a momentum for us in the EU to push this agenda. It's also momentum being generated from the global level, and we are working in the broader context of the adoption, but also the implementation of 3 action plans from the WHO, which are really key to us. One on mental health, one on dementia, and another one on epilepsy and neurological disorders. So with all of that, we really consider we have captured a significant portion of our space, of the brain health space. But what is really key is that the next 5 years are really going to be instrumental in meeting the objectives of those global action plans. That's obviously the duration of the upcoming mandate. And we are hopeful that by 2030, with a coordination strategy at EU level, we can accompany the delivery and implementation of those global action plans. That's also why we have been working at the level of the United Nations, being present at the General Assembly of the UN. This is now a continued presence. We have also initiated a global brain coalition. But what we actually learned in that global engagement effort was that other countries and other regions of the world have been prioritizing brain health, but also concepts like the brain capital and brain economy, up to the point that this is going to be central in their government's agenda. That's the case of the Republic of Cameroon, when they adopted over the summer what is called the Yaoundé Declaration on the brain economy, brain health, and brain capital. So it's basically embracing that notion that the brain is more than an organ. It's more than an organ that can dysfunction at a certain course of our life, but it's also the best assets that we have for us as individuals, for us collectively as a society, but also to contribute to the development of our economy. And the notion and the nurturing of our brain skills is definitely something that ought to be better prioritized also in this broader vision. Just a quick last word, also to promote the Brain Innovation Days that EBC has now started to organize a couple of years ago, that is now becoming an annual event. But that's the reason why I would like to conclude on that particular event is that first and foremost, it's not only an event, but it's a platform of ongoing engagement of all the tiers in our community, but also beyond. So the collaboration that we are going to discuss today can definitely build on successful and successive other examples of collaboration, and we are happy to welcome the initiative at our next meeting in the future. Thank you very much for your attention.
Thank you, Frédéric. And thank you all for setting the scene for what is coming, actually, the 3 sessions that we will have. It would be inconceivable to talk about non-communicable diseases without putting them into the context of the global world and environment that we are living in. With the speakers of the first panel, we are going to address several diseases and pandemics, as well as the changes we have to implement. And I would like to call our 3 speakers, so Professor Debarati Gouassapir, Professor Antoine Flahault, and Professor Prisco Piscitelli. Please join me on stage. I do not see Debarati. Ah, you're here. Come. I have the light there, so please come and join me. Have a seat. You can each take a microphone. I think it will be necessary, actually. Hello, good morning. Come on in. Make yourself at home. So we have 80 minutes to discuss this further. So I will now introduce you to the audience. So Debarati Gouassapir, you are an epidemiologist. You are the founding director of the Center for Research on the Epidemiology of Disaster at UC Louvain in Belgium. And you also are a senior fellow at Johns Hopkins University in Baltimore. Professor Antoine Flahault, thank you for being here. You founded the French School of Public Health and the Geneva-based Institute of Global Health, of which you are now the director. You also are the dean of the Swiss School of Public Health in Zurich. Professor Prisco Piscitelli, Buongiorno. You are an environmental epidemiologist. You are the president of the International Environmental Health Research Organization and a member of the board of the UNESCO Chair on Health Education and Sustainable Development of the University Federico II in Naples. As you can imagine, based on our speakers' area of expertise, we are going to talk about diseases such as cancer, obesity, and also we are going to talk about natural disaster whose impact on people's health can vary depending on where they live on the planet. This debate will take place here on stage, and as you can see regularly on the screen, there is also a QR code that you can use. We would like you in the audience to share either your professional expertise, but also your patient experience, if you had one, your experience, someone of your family's experience that is really interesting for this debate. Of course, if you do not want to raise your hand and ask a question, you can use this QR code and send us a question through Slido. This is also what we invite you to do if you are at home or at the office and are watching us on the internet. So we'll start this debate with prevention. Professor Flao, my first question will be on prevention. We already heard a lot about prevention during the keynote speeches. And this is going to be a recurring point of discussion. It can make all the difference in terms of both healthcare and environmental protection because it is completely connected, actually.
Yes, thank you for this question. And I would like to take the opportunity to thank the organizer for having invited me to discuss with you. You know, talking about prevention is a bit strange. You could say, why prevention? We are living so long in Europe. We have the highest life expectancy. Do you want to prolong life again? Do you want to tap in our pensions and to destroy our economy with prevention? So it's not so intuitive that in fact life expectancy is probably not driven so much by prevention. It's driven by income, it's driven by our education, which is very high in Europe. It's also, of course, driven by the healthcare system, for sure, and probably a bit by prevention. But when you see the healthy life years, I mean the life expectancy without disability when you are 65. There are huge discrepancies in Europe. For instance, in Sweden and in Nordic countries, they benefit from 7 to 10 years longer than in Belgium or in Switzerland or in France or in Germany. Meaning that, for me, this is probably one thing which is an indicator of the level of prevention in a country. If you are, you know, our countries are able to prolong life up to more than 85 in average for most of the population, even with disability. But when you can live 10 years longer than in Belgium, in Sweden, at the age of 65, it's probably because you have implemented all along the life some good preventive measures we have to look for. And that is maybe the point. And the other point is it means that prevention is absolutely not dedicated to prolong life. It's just dedicated to prolong the healthy life years within our capital, as for the brain health, our capital of health. We have 85 years to live, maybe 90, hopefully. We need to live them in the better health conditions as possible. It's good for our healthcare. It will be good for our economy because it will save a lot of money. We will not tap more on pensions because we will not prolong lives. We will only save disabilities, save chronic conditions. We will also save the climate. It's a One Health project, and we will see how we can save the planet and the carbon footprint thanks to prevention.
Thank you. Professor Pescitelli, this is especially true when it comes to epigenetics. And maybe some of the people here or on the internet are not really familiar with... Do you have a problem with the microphone? Yes. Change it maybe. So for those who are not familiar with this, maybe you could explain what it is exactly and also share with us some facts and figures. What's happening here?
Thanks.
Microphones.
Thanks. So, what Professor was saying is really very, very interesting because, and it's probably also related to cultural factors, no? So that now we usually also say that culture is health. And that's maybe true. It could be a crucial preventive factor. Of course, when we speak about prevention, we would like to speak about primary prevention. This is a link that is putting us also in the environmental issues concerning prevention. We would like that people do not become sick. That vulnerable people do not become sick, especially young people and children, of course. It was interesting to listen to the previous speakers and to the figures presented by Sandra Gallina about the incidence of cancer and brain cancer in children. If somebody here, I think that everybody agree that we should not become used to conceive increases in childhood cancer, while we are observing continuously increasing rates in young adults and children cancers. This should trigger in our minds a new kind of explanation for that. That's the key point of introducing the epigenetic model. The epigenetic model is something very interesting because it tells us that the environmental exposures, so the exposures, the contaminants we are exposed to, which begin during the pregnancy, no? You know, the Endocrine Society tells us that there are about 96 molecules that are potentially endocrine interference in the womb. So the exposures starts very, very early, even before the birth. And this kind of exposures continuously are continuously present during the life of children, of young adults, and so on. So what we are observing is a kind of epidemiological shift, because just speaking about cancer, if we were remaining in the traditional model of casual somatic mutations, we should have observed, professors, we are all epidemiologists here, cancer cases, almost all cancer cases in elderly people. Yeah, we observe the majority of them in elderly people, but we observe the highest increase in younger people. That is something that needs a different explanation. If we adopt the right explanation, we can open really new perspective for primary prevention. And there is also a convention, an international convention, the Rio Convention, that states at Article 174 that states, nations have to adopt the right explanations for health issues in order to foster the prevention of diseases. And the good news in adopting the epigenetic model is that epigenetic alterations, that means those alterations that are triggered by the exposures that interest not the genes, but what activates genes or oncogenes or oncosuppressor genes, they are reversible. That's good news. This good news should allow us to foster and to explore a new perspective for primary prevention, because we don't want our children to become sick. We don't want our children to experience annual increases in incidence of cancer when we have got used to see in our reports annual increases in children cancer. Is it that something which is good? No. I wrote an editorial last year, and I promise it's my last sentence. Vanessa travels with me.
I'm a cop, you know.
The title of this article, it was translated in the journal of the School of Public Health of Lugano by Luca Crivelli. More children means more cancers. So is something we should not get to be used to, and I would finish with the definition of cancer that was stated in the Treccani Encyclopedic Dictionary in Italy, which is something like the Bible in Italy, in 1955. The definition of cancer in 1955 in the Treccani Encyclopedic Dictionary was professional diseases of workers of chemical industry. So it was clear what kind of exposure were linked to the development of this disease. And then we have to ask why, when, and how these exposures that were limited to working populations got generalized to the general population and are for sure a main factor that is affecting our young people's health. Thanks.
Thank you. We'll get back to this. Professor Gouassop here, talking about One Health obviously leads us to talk about disasters, and these disasters have a huge impact on public health.
Right, thank you.
No, it's okay.
It's on. I think everyone can hear me.
It is.
Yes? Good. Yeah. Well, thank you for inviting me, the organizing committee, and especially Michelle, who invited me to this forum, and I'm really happy to be here today. So, my area of work, as Vanessa mentioned, are natural disasters. So I'm specialized in the epidemiology of natural disasters. Of the natural disasters that occur in the world, and I'm not going to go into mind-numbing detail about definitions and so on and so forth, it's going to bore everyone to tears. The natural disasters today are about nearly 90% are all climate disasters, right? So they're climate extremes. Heat waves, floods, storms, droughts, what else do we have? Wildfires. So all of these disasters constitute nearly 90% of all natural disasters in the world, and they are the most frequent and increasing in severity. This is an important piece of information because when I started in this area, it was a very marginal topic. 30 years ago, it was, oh, Madame Catastrophe, est-ce que vous créez la catastrophe, ou est-ce que vous... It's all kinds of jokes. Now people are not joking anymore about climate extremes. People are not joking anymore about climate extremes. Now, what I would like to point out here is that the link to climate disasters and public health, and in particular, One Health, the topic of this particular conference, is that climate extremes or climate disasters, it's an easier word to remember, climate disasters actually affect very profoundly the plant kingdom, the animal kingdom, and the human communities, right? All three of these major sectors, which are part of the One Health concept, are deeply affected today by climate extremes. And what happens is actually the environmental and ecological changes in the area which is affected by any kind of climate extremes. I mean, let's just take one of the most important ones and one of the most neglected ones. heat waves. Heat waves, people have started talking about it now, but in fact, it was a very under-researched disaster. And why was that? Why was heat waves under-researched? Because it's epidemiologically, and even in any other format, it's very difficult to measure anything. Very difficult to measure. How do you measure the impact of heat waves, except for heat stress? And in developed countries like the ones we are now, you get the heat stress in the hospital records and things. But in poor countries, you don't. So there's no real measure for heat waves. Heat waves will change completely the ecology of an area, right? The ecology of an area, the environment, the vector population, the way vectors behave, the transmission of disease, all of that changes. So these are some of the ways, and this is not only for it, but floods have the same thing. Floods have the same thing. You have a major flood, and you will get outbreaks of dengue, outbreaks of malaria. You will also get, which is very important, talking of non-communicable diseases, there is a huge peak in malnutrition in children because harvests are lost. People don't have food for 3 or 4 months, and in very small children, I don't mean small children, but small children, in small children, loss of food, loss of calories at an early age has a lifelong impact, and I'm sure Antoine will, is lifelong impact. So these are things that connect up climate disasters to public health and connect up the animal kingdom and the plant kingdom in very, very close relationships.
Mm-hmm. Thank you. We'll talk about nutrition, but in another aspect. Here we're talking about malnutrition, but I would like to talk about preventing obesity, which is completely opposite, and that's true that the part of the world we are living in is so much important. Here to prevent obesity and to prevent diabetes to happen, which is more something that we know here in Europe and also in the US, I mean in our part of the world. You actually studied Mediterranean diet, and there are a number of benefits, we know that, but the thing is that this kind of med diet can also be applied to other countries, even in China. So that's a kind of a list of principles that we all should take and take the habit to eat this way.
Yes, what we have developed as our UNESCO chair on health education and sustainable development of Federico II University of Naples is an interesting proposal because we are fostering the application of healthy nutritional principles of Mediterranean diet that can be applied in every part of the world by using locally produced food. We call it this kind of project a planetarian diet. We have published already several articles in scientific literature, and we already published nutritional pyramids for every continent, including Asia, as you were mentioning, because there are food that can be used to follow the healthy nutritional principle of Mediterranean diet everywhere.
And what you did is actually that you recently published a research that has been conducted in schools in Italy. So you replaced junk food by med diet. But
that is,
the methodology was also something.
Methodology was very interesting because we have demonstrated that it is possible to obtain a changing of behavior, nutritional behavior in school children by using non-conventional approaches based on narrative pedagogy. So, and the laboratories. If you do not use a traditional kind of education to pass this kind of message to children, they really can be involved in changing their nutritional behavior, and we measured the adherence to Mediterranean diet by using a Predimed questionnaire, so validated scores for that, in the group that was exposed to this kind of non-conventional education based on narrative pedagogy and artistic laboratories versus school children that were exposed to conventional educational strategy.
Mm-hmm. Professor Flau, are dietary policies a necessary tool now in this modern world that we have, and also this world that children also can access food very quickly because they also have money on their phone, in their pockets. So, is a dietary policy something that we really need?
Yes, in fact, just to come back to one point you mentioned, malnutrition is not totally the opposite of obesity. There are some families in the world where some children suffer from malnutrition and others from obesity. So it is something which is almost the two faces of the same coin. Yes, we know today that unhealthy diets have a huge cost, both on our health, but also on our planet. On our health, it has been estimated that we could save 10 million premature deaths with healthy diets, with diets recommended by Prisco, the MED, but also the Japanese one, or sometimes some other kinds of healthy diets. On the planet, it's probably less well known that, in fact, 37% of the greenhouse gas emissions are produced by the food and agriculture sector, and 80% of them are only produced by the livestock. So we are red meat eaters, and we should maybe not become vegan or vegetarians, it's not the issue, but at least reduce dramatically the consumption of these red meats and the ultra-processed food. So you're right that there are some policies. We have to translate this knowledge into policies, which is not so easy because, of course, it's a question of behavior. We should try to eat better, but it has been shown that the healthy diets are not affordable everywhere. Junk food is often much less expensive than health. So we need to have some public policies, particularly maybe tax policies on sugar, on sodas, and reverse these taxes on healthy food, making them more affordable. The food labeling also, we are all aware of the Nutri-Score in Europe, but it is difficult to implement. There are a lot of lobbies and resistance to implement them. There are some other forms of labeling, like the NOVA labeling. The NOVA labeling is to label the ultra-processed food. Some ultra-processed food are not unhealthy, some are. It's difficult for the consumer just to know if it is what you buy is healthy or not. So all these labeling help. It's not a restriction of our freedom. It's just informing the consumer about what is good for his health, what is not. And there are some other way the public policies can act, like social marketing. You know, in France, 5 fruits and 5 vegetables per day was very productive. So these kind of things are helpful. In Japan, the 10,000 feet steps for walking was also, since the 60s, a very important social marketing. Nudging, you can put in the supermarket the healthy food before and not the sodas or the junk food.
That would be a revolution, huh?
That would be a revolution.
Marketing.
Yeah. And also salt. Salt is one of the key determinants of high blood pressure. And high blood pressure is the major risk factors today in terms of mortality of the population. So having good policies on salt is something which needs some regulations, because we can eat bread and cheese, it's good, but sometimes it's too salty, and we can reduce the salt without too much reducing the taste.
Prisco Buscitelli, new policies compared to education methodology like the one you had for this research, which would produce the more benefits for children, teenagers, young people, or are they both necessary actually?
Antoine was saying really the truth. So there is an economic problem, which is the access to junk food that is something which is less expensive. And even because some foods are even not accessible to a lot of people. So the economic barrier is something that is there. What we can do through education is something that can produce a benefit both on environment, for example, educating children and students to reduce their plastics consumption, for example, like the consumption of cups or bottles made of plastic. It is something that can be done at school, even by fostering the use of tap water, which is something that in Belgium is currently adopted almost everywhere, but not in many other countries, as well as in Belgium. So there is something that can be done also on the environmental education, in addition to the nutritional education, which is something that is really under-practiced, I believe, at school. And even when something is done, it is done in a way which does not become really part of the life of the student. So there is space for new policies, which could even be a result of this conference, which is held in Brussels. So I believe we can state something really in a strong way on that, because European policies should invite national governments to foster new policy and new strategies for a better and a different way of educating students to implement a healthier nutritional style and a healthier environmental commitment in their daily life.
So that you don't feel guilty at all before eating, you have to know that today we have an organic, bioorganic caterer. So everything will be healthy today. So don't worry. Does anyone have a question? That's a good news. Yeah, good, huh? And it's really good also. So no question at... Yes, Delphine? Hello. Oh, you do not have a microphone. Wait. There's one there. So we'll keep this one for us.
Thank you very much. I would like to know the impact of advertisements and what is your position on
the impact of
advertisement?
Advertisements. Something also related to the label policies. I don't know if Antoine, you want to answer.
Antoine Flau, maybe?
The impact of advertisement is huge, but there are more than the impact of advertisement, which is something which is embedded in TV series, in, you know, there are many, particularly American TV series, which show women, ladies, talking together with a glass of red wine. I don't have any problem with red wine, but it's a way to promote that when you have a conversation with someone, you consume red wine. If we could have TV series which embed, like, you know, the telenovelas in Brazil, which were very, very influential for reducing the number of children in women, it has been shown by sociologists, it could be very helpful to have an environment, a media environment, which is prone to favor good behaviors in terms of health. It's not to be too moralistic, it's not to forbid, it's not to say abstinence, don't drink alcohol, and
yes.
but
alcoholics, for example.
Yeah, it's just to try to embed within our media environment much more good practices.
Michel Coleman, you have a question?
Yes, regarding advertisement and coming back to obesity. As you know, we have now these glucagon-like peptide-1 agonists, which I would say are very profitable for several companies. and there is advertisement in the general population about these drugs. So since we will also consider the economical impact of what we are discussing, could you comment on your position on these new drugs to tackle obesity and diabetes?
Say something. Or I don't know if Professor...
Come on, and I will comment after.
No, just in general, if we think that we can address this kind of global epidemic phenomena like obesity, we speak about globesity, this new this neologism that has been invented, or even cancer, for example, just by fostering the cure and not the primary prevention, we are in the wrong way, because the costs of getting an enormous and a huge quantity of people to get them access to grant this, to all these people access to this costly drug for cancer treatment, for obesity treatment, they are so huge that we can even imagine that any healthcare system, even public or based on insurances or private, can afford. So we are on the wrong way if we don't foster primary prevention and we just rely on the cures in general.
If I may, for the first time, I will be a bit controversial on that aspect. My feeling is that the drugs you just mentioned, GLP-1 agonists, are game changers. And we maybe not see that today because they are very recent, but I think that we should at least observe them. And they are game changer because, of course, you are totally right that the first goal is the primary prevention through the change in behaviors. Healthy diets, exercise, physical exercise, less problematic use of alcohol, abstinence of cigarettes. That's clearly the goal. But we face our limits with primary prevention only. And these drugs have proven a lot of efficacy in randomized clinical trials. Since, 22% of the Belgian population is obese. It's not very visible in this audience. Why? Because there is a social gradient with obesity, which is very strong. The most vulnerable segment of the population suffer much more from obesity. And obesity is a risk factor for many conditions, many chronic conditions. You mentioned health brain, but the health brain, it's a determinant of dementia today, which is clearly known. So fighting against obesity, fighting against diabetes, fighting against the consequence of obesity, which has been proven by these drugs more and more. There are not a single day when a new randomized clinical trial with a very strong evidence produce some results which are beneficial for these drugs. I have absolutely no conflicts of interest with regard with these companies and these drugs, I can tell you. But really, as an epidemiologist, I want to observe them with cautious and to think that maybe they will prove to be game changer, probably as the statins have been game changers in hyperlipidemia problems.
We are not in contradiction, because concerning secondary prevention, I totally agree.
Yes, okay. Casimiro here.
Thank you. I have a question for Professor Gibrati. We are aware, and it's well known, the effect of disasters on zoonotic disease and other infectious disease. How much we know about the effects on non-communicable disease, and how much is studied, and actually how the One Health approach can be a solution for that. What the One Sustainable Health for All Foundation, we are producing operational sheets on One Health approach in disaster risk reduction. So I would like to know your point of view. Thank you.
You said operational?
Sheets for analysis. Sheets. Sheets, yeah. Like protocols on One Health approach in disaster risk reduction. And this is what a working group on humanitarian action is developing this tool.
Right.
Yes, of course.
So, just to give you a short answer, because you've asked a question that is quite vast in its implications. The truth is, the humanitarian community, right, who react to climate disasters, to the floods and so on and so forth, it's a very limited, they have a very limited horizon, right? Their role is to go and succor the population, to help the population in the short term. That is their problem, because, and that's linked also to the funding of humanitarian aid. The funding of humanitarian aid has a very short window, so you have to spend the money. By and large, it's changing slowly. You have to spend the money in 3 months, and then they renew it in maybe another 3 months. So in 6 months, you should be finished with your job and you're out of there. That's humanitarian aid in natural disasters. Now, for the operational protocol, I'm just taking bits and pieces of here. So for the operational protocol, that has improved tremendously in the last 20 years. Operational protocol for even WHO, which the Department of Humanitarian Health, of Emergency Health, has become huge. And they have very good protocols, but they are still limited by the time factor. Whereas now, with climate disasters, we find that the time factor is a handicap, because much of the impact comes really after 6 months, 9 months, a year afterwards, including disease transmission, including undernutrition or, bad nutrition, very simply malnutrition. That's what it means, as Antoine said. So I think what has to change now is to realize that, yes, that there is the time factor is an important factor, that climate disasters have important changes in ecology, environment, and animal health, in livestock, and those things have to be packed into the protocol of response. Yeah.
Professor, since you are actually talking about this moment, people arrive and they treat the crisis, actually, I would like to address another problem, another topic with you. That's the lack of information, the lack of data that you have. As you said, you arrive there on a disaster, you try to help people, you have a small window to do it, and then it happens to be that nowhere you have the complete data set. So probably this timing is an explanation, but that's not the only one.
Yeah, so my biostat professor, I have to learn from Madonna,
Yes, that's the Madonna. Next time, if you want, you can have one. That's the Madonna. I will have one for you next time.
So my biostat professor in the first year of my university at Hopkins, he came onto the stage. It was a very big class. And he came onto the stage and he looked at us and he said, "In God we trust. Everybody else must bring data." So I think it's something that's stuck in my head.
I like this one.
Something that's stuck in my head. And I think for climate disasters and relationship to human health, livestock health, animal health, and plant health, if there is no strong evidence base, which my two colleagues here have mentioned, for certain areas, the evidence base is very strong. Why? Because money is involved. Money is involved. Pharmaceutical companies need the data because they're going to sell their product at huge margins, right? So money is involved. So suddenly you have the data. For the impact of climate extremes on human health, data is very scarce, systematic data. You can have it for one country, for Mozambique. You can have it for Belgium. Belgium, this is a rich country, this is not a problem, the floods, you can have data. But you don't have anything at a global scale. What you have at a global scale, and this is an important concept to keep in mind even for what you have at the global scale are discipline-specific data. So what do we have? We have the MDAT data, which Vanessa mentioned, which I founded 30 years ago. You have the disaster impact on human populations. You have environmental data, Max Planck Institute in Jena. They keep environmental data on all climate disasters. Socioeconomic data, Radboud University in the Netherlands, they keep So each one of them have these silos of data. And until we break those silos, not only for climate disasters and human health, but for almost any other area of science, unless we break the silos, we will never get a One Health concept. That will not work. That will not work. And somehow scientists have to be convinced, and it's not very easy, scientists have to be convinced to share their data.
We have a question there. Could someone, Caroline, over there? No, wait, because people on the internet, they won't hear you. So if you do not have a microphone, maybe, yes, we can lend one to you. Voilà, Caro.
Matthias has been waiting.
Matthias also. Matthias, maybe the time we go to the...
Okay, well, thank you for this great debate and great conference in general. I wanted to come back to Michelle's question about the anti-diabetes and anti-obesity drugs. I understand both of your point of view. I do think we don't want to be in this equilibrium where everybody starts taking these drugs because they want to continue eating junk food. Especially since, and there I don't know about the scientific evidence, there may be an opioid-like property of these drugs that somehow, in the short term, they work very well. Just like, opioids, you want them to, if you have an operation, not to mention terminal cancer, but not for back pain, because basically it won't work. So I hear that people who take these drugs and then they stop it, then they get back their weight. And so that I think is a big issue, especially if we don't manage. And it is amazing the power of the junk food industry. We have this, to get a vaccine approved, you need to do a lot of things, a lot of tests, but randomized controlled trials are not needed for Big Mac. So at some level, we need to think indeed globally in terms of solving these issues together, I guess. And it's very, very complicated.
Antoine.
Yes, I think it's what you are saying is very important. We need to be cautious. We need to see the safety profile of these new drugs. But we have to know that these drugs are not totally new. We have now cohorts of randomized clinical trials followed up for more than 3 years. And what we see is that they are, for the moment, not prone to a lot of adverse events. There are some gastrointestinal adverse events, which are frequent but very not severe, but sometimes severe enough to stop the drugs. So there are a problem of compliance. All of the patients will not continue the drugs, which is sure. And the second point is that it is true. There are some trials which show that after 1 year of stopping the drugs, it continues to have a good effect on the weight, for instance. But what is sure is that the weight is rising again when you stop the drug. Like the statin, you have to take the statin for all your life, almost, when you have an hypercholesterolemia. So it is, and for high blood pressure too. So it's possible that these drugs will need to be taken for a long time. It's true that they are too expensive, maybe not completely affordable for our health system. So we need economists here to see, because if they avoid some complications, some long-term effects of obesity, maybe it will be helpful to have them, even at a price. So for the moment, it's a bit early to have a sharp and definitive conclusion, but we need to remain open. It's what I wanted to say.
Thank you. We had a question there. Was it about the lack of data?
Well, I want to reply to Deborati.
Yeah.
It is nice bringing down the silos, but have you ever thought about the enormous cost due to the standardization of the system involved? Because they should communicate. They are now using certain technologies, but at the same time, there is no consistency about that. So you are collecting data that ultimately you cannot use even.
Yes, of course.
Yeah, you're right, but it's recognized very well. Now, we have started a new initiative called MERGE.
Yes.
And the MERGE initiative, funded by the Rockefeller Foundation
in
New York, and for which I'm going to be leaving in about 20 minutes. The MERGE initiative, it's really new. The MERGE initiative, you're spot on, brings together 6 of the biggest global data sets, 6. We've just chosen 6 because we know them and they come from 6 different disciplines, right? So the Max Planck guys are there, the Columbia Climate School is there, and so on and so forth. World Pop, Southampton University. So there are 6 of them. The biggest challenge, people want data. I'm getting calls from World Bank, where's the data? Do you have any data? Can you send the data? The biggest challenge and the most expensive challenge, but for which we have the funding, most expensive challenge is exactly what you're saying, is integration and harmonization.
So, also quality of the data,
yes,
also quality.
Absolutely, but here, we have avoided a little bit that problem by taking databases from scientific groups who are at the top of their métier, top of their profession. So we've avoided that. But the biggest expense is this integration and harmonization. And the problem with integration and harmonization is that it is a non-visible good. You can't show anything for it. You have data, you can show it. Integration and harmonization procedures is an invisible good. And so we've had a lot of effort to get the funding for it, but we'll get there. We'll get there.
We have another question for you, Professor, I think, just the time the microphone arrives.
Hi, I'm Tatiana Ravenko. I'm really glad that we touched this point, the question about data sharing, because it's something that stays really in my heart as a scientist, as a former researcher, when I was searching the potential treatment for metastatic disease. And this is one of the motor why I founded Medical Data Hub, which aims exactly to promote the data sharing within the scientific community and in the healthcare sector. So we are supporting organizations to do it, but however, I see there is a lot of non-willingness to share the data. And I wanted to ask you, in your opinion, what can we do, or how can we improve to motivate to share the data within this community? Thank you.
So, I've spent many years thinking about this because we've had all kinds of issues with our data. So we have a database, international database, which has become the unique database. What happened? 2 things have happened, and one is doable, the other is to be tested. One is that this whole database on the human impact of climate disasters was funded by the US government. For 30 years, they funded it, without question, completely every single year, 30 years. What did they do? They made us sign, before we get a grant, that this is public data, and all of it has to be available to anybody. And we've had issues with it. We have an American professor in Texas who yelled and screamed because we did not release part of it because we were not sure it was not validated. So one thing you can do is this, to have the granting agencies agree to put in a clause saying any data that has been, that we have funded you for should be put on a public platform. It exists to a certain extent. The second thing that I think is is more of a carrot rather than a whip. The carrot is what we are doing for MERGE. What have we done for MERGE? These are big data sets that exist for certain disciplines, right? Now you have to give them a carrot. Why should Max Planck agree to share the data? Why should they? They don't need to. They are a big institution. The only way you can help, you can attract them in, is by saying you are going to get 500,000 more hits per week on your website. You will get visibility, much higher visibility than you will ever get staying in your little specialized ecology guys, only those guys are looking. So you have to put in a carrot. So you need a carrot and you need a whip. And the whip is grant funding organizations have to make you sign, saying that any data is public data. And second is to attract people to share the data by saying you will get more visibility. You will be on everybody's citation. Those are the only things I can think of pragmatically over time.
How about those in private sector? Because how about those in private sector, like small startups, medtechs?
You know, one of the private sector partners that we have who are really difficult, but not entirely, is Munich Reinsurance, right? You've heard of Munich Reinsurance, one of the biggest reinsurance companies in the world. So we work with Munich Reinsurance and we work with Swiss Reinsurance. It's very hard to get data. They have very, very good data all over the world because they have offices all over the world. That honestly, to be honest with you, you can only count on goodwill and sweet behavior. That's it. You have to be sweet to them, and you have to go to Munich 3 times a year. You have to be nice, and Petra will then give you access to the data.
We have a question here, or a reaction, I don't know.
Hi, Brian Rudkin, One Sustainable Health for All Foundation, One Europe for Global Health Coordinator. We organized an event, Benoit mentioned it, during the World Health Summit at the French Embassy in Berlin on One Digital Health. And one of the issues was getting people to share data. It's very difficult to get sharing of data across the hallway in some institutions, let alone across the street, and let's not talk about countries. So Jai Ganesh Udayan Sankaran, Executive Director of Asia eHealth Information Network in India, shared with us how he was able to get not 1, not 3, 15 countries to share essential data. And it was absolutely, he gave us a roadmap on how to do that. And he will be sharing that through our network. And just a comment, it is possible, not easy, but it is possible. You just have to work with people and, as you say, show them what the carrot is by doing so. We also had in Fiocruz, a very major foundation in Brazil, saying, oh, you're telling us, the global north, that data is very difficult to get in the global south. Well, that's wrong. We have data, essential health data, climate data, environment data on where people are living for over 120 million people. And by the way, we're putting it up to 200-something million next month. So they are very active and very clearly doing what you're saying, being able to bring in this data and then use it for AI analysis, for example, in a concerted manner. I just wanted to put in that call for statement of it is possible, people are doing it, let's get on the boat and make it happen. Thank you.
Thank you for sharing. We have a last question over there, and then we'll keep going with this debate.
Thank you. It kind of goes back on the concept that people are talking about the last couple of questions. So people are talking about data, about reusability, etc. There are already a lot of these principles out there. For example, the FAIR principles, which have now also been taken into the EHDS, the European Health Data Space. So we're talking about integration and harmonization. We should talk about semantics. So what are we talking about? What do you mean with these types of data? It doesn't have to be shared. It can be visited. My data doesn't have to move from one country to the other because I have legal obligations in my country. It doesn't have to move there. You can move your analysis towards me. So these concepts are already out there. We just need to implement them. We just need to make the next step. So it's not about reinventing the wheel. It's looking at the wheels that we already have. So that's just my final comment. Thank you.
I actually, at the New York meeting tomorrow and the day after, there's this fair. The lady who's, Christine Kirkpatrick in San Francisco, she leads the fair thing. So they are doing, NIH is funding them for a great deal of promotion. There is a lot of legwork involved. You have to go from place to place and essentially sell your product. And it is getting done. And I think the scientific community is sort of being forced to realize, or realizing themselves, that it is in their benefit to share the data, because then you can get it from other people as well. And I think that is a very important carrot, that your data is not only being looked at by ecologists, but they are also being looked at by sociologists and by demographers. Why not? Suddenly your vision, your clientele, if you like, opens up enormously. That's a carrot.
We have also to say that when we now publish a paper, it is always written before the submission, no? How you will be, how your data will be made available to the readers, and you have to state that how, even if you write upon request by email, but you have to state that. So that's an interesting, good news also.
I would like now to move further on the debate on One Health. Data is super important for each of the topics we will be addressing today, obviously. But regarding One Health, Professor Pescitelli, there is actually a virtuous circle. We understood that from what Professor Guasapir already said. But just a second to take some attention on this, because that's amazing how you do that. We are talking, you can't see that, but it's here. So basically, everything is there. That's, I could read pages, but you just draw sketches. That's so, yeah, congratulations and thank you. So yes, regarding this virtuous cycle, maybe that is important also to talk about the habits, the bad habits we have. We have cities that are spread. We work like half an hour away from our work.
We go there by car.
Yes, but no, with the car maybe half an hour, and no, it's in the highway traffic. It's too. So there is a concept which is the 15-minute city concept that could actually potentially be good as well for health and for footprint, carbon footprint.
15 minutes. You know, the 15 minutes that you need to get everywhere by not using the car. There is also in this kind of a concept a new superblock model that has been proposed by the ESG Global in Barcelona, which means also to involve other kind of specialists. You know, the One Health concept is something which is totally interdisciplinary, because architects are involved, engineers are involved. For example, to improve indoor air quality. Indoor air quality is 3 to 5 times worse than the air quality outside, which is quite bad. Not like in China or in India, but they are making a lot of efforts on that. People who have studied chemistry, people who have studied even economy, everybody is involved in the One Health, approach. So this means that, for example, if the major contributor to the PM 2.5 in our cities are the systems, the heating systems of our houses, it is not a question for medical doctors. So somebody else has to take care about that. No? And even mobility is not a question for medical doctors that can be addressed by medical doctors. Yeah, we can produce data that about what is bad for our health, but to provide solutions, we have to involve many other specialists in a lot of different disciplines. And what about, for example, the impact? We are speaking about climatic disasters, but how to cope with the climatic change? What kind of mitigation strategies, adaptation strategies must be implemented in our cities to reduce, for example, the impact of high temperatures or the impact of rain, which is massive sometimes. All these things must be addressed in an interdisciplinary way.
Antoine Flao, there's also something very challenging. We know that in cities like the ones we have, big cities, probably it's different when you are outside the cities, but in the cities, isolation is also the cause of dramatic diseases. I mean, brain disorders, dementia, health problem also. That's also something that we can address.
What a good transition to the next panel on brain health. You're totally right. The Lancet has published an update of its Lancet Commission on dementia and cognitive disorders with aging, and identified 14 major determinants of dementia, and social isolation and loneliness is one of them. It is totally true. And another paper which has been published in Nature Mental Health last month showed that loneliness is account for the risk of dementia by an increase of 30%. So it's a huge issue to try to tackle loneliness and social isolation, and it's not easy. 1/3 of adults in the US population suffer from loneliness and social isolation. The cause are, the breakup of a loved one or the death of a loved one, the unemployment, the retirement, sometimes the poverty, the intimate partner violence. So it's very diverse. Remote location where you live, addictions, mental health issues also, and chronic disease are favoring social isolation. So it's difficult to find some public policies to try to tackle the issue. Maybe we can see what the Japanese are doing. The Japanese have created the concept of moai. Moai is a Japanese term which means social mutual groups. So you belong to 5 or 7 moais when you are a Japanese citizen, meaning that you have mates, colleagues, former colleagues, fellow mates. You keep them for all your life, 5 or 6 of them, and you share your patients, you share your hobbies, your activities with them. You are not alone. So fighting against loneliness is very, very important. And the NIH proposed 6 ways to fight against social isolation. They said hobbies. Go to your hobbies. Volunteering, trying to volunteer is something which creates some social networks. The pet therapy, having a dog, it's very interesting to see that when you have a dog, you have to go outside. And to walk and to meet people and to talk with people. You don't have to, but it's a way.
Well, people talk to you when you have a nice dog, actually. I can see that with my nieces. Yeah. They have a lot of friends around.
Exactly. That creates some, yeah. And cats are known to lower the blood pressure and the stress. So caregiving also. Social networks, but not virtual social networks, real social networks, and physical exercise to try to go and walk. Walking is so important. So it's interesting because it's really One Health. We are not, as you mentioned, it's not about doctors here. It's really social lives. We could add air pollution, which is also another factors of dementia and brain health issues, as you mentioned, the indoor and the outdoor air pollution. So for sure, it is true that we are facing a One Health aspect of here the brain health, which is not only a question of drugs or medical interventions, but also of tackling the issues with all the social components and the political components.
Yeah, but actually I will start from this and from all what has been said. And I have a question that we didn't plan, but hearing from what you said, I'm actually wondering if we shouldn't change or maybe think about it, the programs of the schools. I mean, for children, we are talking about One Health. And if you go to many conferences in the scientific field, you had a lot of One Health conference already. In one aspect or another, this is a topic that has already been addressed. But when you see all the connections, the planet, the health, everything that you can have, I mean, later in life, everything is connected. So shouldn't we maybe think about the fact to have like a special class for children 1 year after another and teaching them how everything is related to? Debbie, I think it's on, actually, you know.
I'm trying to turn it off.
Yes. Ah, no, you don't want to talk. Okay, fine, so. Professor Piscitelli.
No. You know, as we were saying, it is a kind of interdisciplinary matter. So maybe instead of having a specific One Health teaching, we should make aware that every teacher, independently from the subject he or she is going to teach, might address also this kind of aspect. And this is something that happens usually now, even with civic education.
I will interrupt you just for a second because Deborah T, who was up here, has to leave. Sorry for that, but we can thank her. Have a good flight to New York and bring us some data.
Nice trip.
Sorry, sorry that I had to interrupt. So
I just
go going. Yes, Antoine Flau, everything, something to say about that?
No, I think it was you raised a very important point for two reasons. First of all, because prevention is all along the life, and it starts, as you said, probably before the conception, before the birth, but during the school age, it's very important to try to train. And we saw that education is a key element also for prevention. And the second point is the concept of health in all policies. In fact, it's not a question of doctors, as we repeated again, but it should be in all policies. You mentioned the 15-minute city. It's about urbanism. We mentioned agriculture and food. We mentioned social isolation. We mentioned the climate and the economic sector. So for sure, it's an health in all policy matter.
Thank you. I see there's one question, and this will be the last one before we stop for the lunch break.
Now the pressure is
Thank you.
high.
No. Keep it short.
So that the question will be a good one. I don't know. Can we also maybe briefly address affordability? So in one of the opening remarks also we heard about income as one of the determining factors. So now when I'm thinking of improving education into this direction, cutting down on the ad, etc. It's also expensive. So when I'm thinking of, going to the supermarket, then we have, the organic food that is very expensive. So even
we already spoke about it, but yes, you're right. It is something that is crucial, actually. Yeah?
Yes, it's probably even more important than what you mentioned. It's good to finish by this remark because the social gradient of disease and particularly of chronic conditions is huge, and prevention is well accepted and well adopted by educated and wealthy people. So your question is major. There is probably no one here who is not thinking about prevention, about walking, about healthy food. You mentioned that we will have healthy food today at lunch. It is sure, it is almost for granted. It is not when you are in the poor segment of the population. So even you mentioned the advertisement, you mentioned all our environment, we need to address the problem of the social gradient of this disease and of prevention. I totally and fully agree with you.
Thank you. Thank you, both of you, because it was super interesting. Thank you all also for participating and asking so many questions. We will now have this lunch break with super healthy food, organic food also. You will see we will be back at 1 p.m. So if you are watching from home, let's get back at 1 p.m. for a session on societal and economic impact of brain health. And if you are here at the Palace of the Academies, you can also stop by the virtual reality area. You will discover solutions for professionals to train their skills and also to simulate emergency situation. I will leave you with this, and as we say here in Belgium, bon appétit. Thank you. Merci. Yeah, thank you. Good afternoon to those who are joining us for this session. Welcome back to those who were already there this morning. Let's start this afternoon with a session dedicated to social and economic impact of brain health. Brain disorders, as we heard already, even from the EU, is the leading cause of disability worldwide and also in Europe. And the number of cases is still rising. In a society where brain capital is seen as an economic driver, what can we do to improve the situation, and which are the innovations we should work for? To answer this question, we will have three panelists with us. I will call Peter Falkay. Professor Falkay, please join us. And we'll call also Professor Kevin Rostasi and Professor Serge Goldman. Please be welcome on stage. So have a seat and a microphone, so that we can start. And I will start with introducing you, Professor Falkay. Have a seat. So, Professor Falkay, you are the treasurer of the European Brain Council, the past president of the European Psychiatry Association. You also are the director of the Max Planck Institute of Psychiatry, as well as clinic director at the Munich Center for Neuroscience. Your main research interest is focused on neurobiology and treatment of psychotic disorders, namely schizophrenia. Professor Kevin Rostasi, good afternoon. You are the president of the European Paediatric Neurology Society, which is one of the member associations of the European Brain Council that has been deeply involved in creating this session. You also are the head of pediatric neurology at Children's Hospital, and there I will need you, Datteln in Germany. Your main field of clinical and research interest is in neuroimmunology. You advocate strongly for equitable access to the highest standard of patient care in neurology for children. And Professor Serge Goldman, good afternoon. You are a neurologist and a specialist in nuclear medicine at the Brussels University Hospital and at the ULB in Brussels. Your main field of research is imaging of brain tumors, with a particular stress put on the integration of molecular imaging in therapy targeting. Another one is functional neuroimaging for neurological disorders. So we just heard, for those who were here with us this morning, and those also who are online. And I actually interrupt for a second just to remind you that you can participate. You will see a QR code on the screen. It is also displayed on your screen if you are at home or at the office. Please do not hesitate to raise some questions. Also, do not hesitate here in the audience to share your professional expertise, and also to share as a patient or as a family member of a patient, to share your experience, good or bad. You know that this can help us to make evolve the debate. So we talked about disasters this morning, pandemics, climate change, other crises that we haven't talked about. There are wars, and they are major conditions that have a significant impact actually on brain health. And since we had this session just before, I would like to continue on this topic, and then we will change topic during this session. So Professor Rostasi, children and teenagers are no exception, and actually the impact of this kind of event can really be quite strong in their case.
I fully agree with this statement, and especially the long COVID or the COVID pandemic, but also, for example, the war in Ukraine are two examples where children are very much affected but get very little attention. And just because this happened last week, the Ukraine Paediatric Neurology Association asked us for a statement and help for a letter sent to the WHO and Lancet Neurology. I had to learn that about 2 to 3 million children still in the country will suffer from some form of PTBS. Now, this is, I think, an incredible number. With few doctors, with no appointments to reach, with very difficult access to tertiary care centers. And I guess, and Professor Falkay could probably allude more to that, that the long-term problems of PTBS are in children probably still unknown and very much dependent on the various incidents.
It is quite awkward because in the beginning of the war, people were thinking about oncology. I remember children being displaced from one place to another to get their treatment, but it is true that brain health hasn't been addressed from the beginning of the conflict, at least in the international, on the international scene. Peter Falk,
can I add one point?
Yes, of course.
We are very good on, for example, treating children from the Ukraine or any other place with multiple sclerosis drugs. These are single patients and they get some publicity and they make you feel good, but the broad scale, it's unbelievable.
Peter Falk, anxiety is the common feature, actually, of all these situations.
Well, I mean, if you think about, I mean, just PTBS was raised. PTBS is the basis, so post-traumatic stress disorder, actually causing about a third, or let's say, well, influencing the outcome, out of a third of patients with depression and with anxiety disorder and personality disorder. So if we think about that, about 60% of people facing war and crime, so man-made disasters of this kind, they will actually have an increased risk of a developing mental illness. So I think that it's obvious if you don't offer people an early help, prevention, you know, we're just running into a big problem, like in every war like that.
This can also affect, Serge Goldman, the cognitive functions of individuals.
Yes, that's of course very important, and actually it starts very early, and that's very important to think about the children on that point of view. You always think about developmental disorders and neurodegeneration as totally independent, which is absolutely not true. And we will probably discuss that a little bit later. And so the effect that the stress imposed to these children will affect the way they will deal with neuronal dysfunction that will come very late in life. And because it's crucial to build some kind of what I would call cognitive reserves, the capacity to deal with any kind of cognitive activities very late in life, when it starts to be more difficult to do that. And it really starts very early, this development. So just to speak about stress and the cognitive effects of war, I would just mention that aspect. Now, there are other problems that the brain suffer from during any kind of disasters, but just to stay on the stress aspect, I think it's important to mention that.
Yeah, sure. We will talk about prevention, which helps actually a lot to avoid some diseases that have been mentioned. In this case, obviously, prevention is quite difficult. It could be addressed, though, making some guidelines for the people that are concerned. But here, let's spend a few minutes on prevention. It doesn't cost much, actually. That's the cheapest way to solve problems, and it is essential. We heard this morning, Kevin Rosasi, that some problems can be avoided even in the womb, so before birth child.
Yep. Again, I fully agree. And I love the comment by the Italian colleague who said that you have to start Italian diet in some form. I'm a fanatic. Very early. And I think this is mainly true. For example, prevention of infection, toxoplasmosis, CMV are very instrumental. I mean, these are obvious cases. I learned that nearly 70 to 80 pollutants can influence cancer development in a woman who is pregnant and exposed. So these are tremendous challenges. Good nutrition, good environment, PTBS of the woman then delivering a child is fetal neurology will be a whole new discipline in pediatrics. Many clinics develop, for example, this kind of approach where the geneticists, the radiologist, the pediatrician sit together and discuss cases. So there will be more and more focus of this very important.
Professor Goldman, recently, Recently, Professor Goldman, studies indicates that some degenerative diseases, that's what you just said, may start with pathological processes occurring at a very young age, though, and I'm talking maybe about Alzheimer, though they can affect people very, very late in life.
Yes, that's a very strange story. The fact that we imagine now that there is a first wave of protein accumulation, abnormal protein accumulation, like the tau protein, for those who knows about the tauopathy, including Alzheimer. And obviously after this first wave, years will elapse before neurodegeneration will start later with a second wave of accumulation. And then we need to think about why this first wave. Is it just genetic? I don't think so, because there are not such a huge familial accumulation of Alzheimer's disease. So it means that there are environmental, in a global sense, effects, life events in this very early phase of childhood that occur. So prevention actually starts there, just at birth. And probably stress, again, in the prenatal, I mean, for the future mother, but also at the postnatal time are probably important to think about, even if the idea is just to protect the population for very late effects of this. So that's important in terms of prevention.
Peter Fakai, we talk about prevention, but there is another point that is super important, that is early detection, because it can change the way, the kind of treatment you can have and the course of the disease also.
Yeah, it's an important point, because I always say, you see, 90% of the population remains healthy, but only 10% will actually develop mental illness, for instance, and actually need support. So what we do with the rest, and so we can't really include everyone in a study. So basically, I think what we need is very early looking at people who then actually change their behaviors, you know, whether depression, anxiety disorder, psychosis, and then really grab them and then offer them early intervention. And therefore, I'm very much calling for a network of early detection and prevention. So it's not waiting until you have everything, you know, the full disease, and then the first stop of chronicity, or even worse, you have the first disease and you don't do anything. And then for sure you have chronicity, which you have about in half of the patients with mental disorders. So I think that's a very important point. Early detection and prevention and intervention.
Yeah, that's probably also the case with something that we really know why now worldwide that is spread, which is burnout. Some people do not address burnout in the first phase. They're just like, okay, this is going to be better after if I change work or if I do some small changes in my life, but then it comes back, actually.
Yeah, and I think, you know, this is something people need to know. I mean, we have spoken in the morning a lot about education.
Yes.
So people need to know that. What is that? What are the key features? Very simple now, 3 sort of key domains. And the second thing is, if you have burnout, this is reversible. So it's important that you actually take action. You refrain from doing your normal, let's say, workload for a certain time. You know, do more exercise, possibly do some psychotherapy to actually change the way you look at things, and you can do a lot. But people don't think, they just say, okay, if I carry on, it will go away. Well, it goes away in some people, but in most it doesn't.
Are there any questions so far? Not at the moment, so I will get back to you.
Not stressed, so
they're not stressed. No, they are so relaxed, and there was no wine, I think. So you're not relaxed because of the wine. Yes.
I would like to add one interesting point.
Yes,
I
sure.
learned from an EBC meeting in January in Basel. There was a colleague from London who presented a project in preventing depression in 17, 16 years old, and they went into the schools and they taught them what is the sign of depression. It turns out that somebody who knows what depression is gets much less depression in the long term. I think that's a NHS has no money, no doctors to treat depression, but they prevent depression in the first place. I think this is very elegant.
Getting the warning signal probably is the most important.
Yeah, and know about it. You know, there's the Saley study by Wasserman. They went to schools, 110 schools, and they just taught young people what is mental health, what is depression, what is suicidal ideations. And they did this 5 times over 2 weeks, 45 minutes each time. So you would say it's okay. And you did a follow-up after 1 year, and you had a significant reduction in suicidal ideations and suicide in this group, who were actually just taught, be attentive of that. And it's not a lot of money, because 45 minutes, 5 times to a young person, this is compared to, a lifelong treatment.
Yes. Yeah, of course. Serge Goldman.
Just to insist on education.
Always education.
So crucial, even for something which is very late. The Lancet just published a list of factors that influence the cognitive decline and how you will deal with the cognitive decline, the neuronal loss. I already said that. First thing, education. That's the first point they mention. And why is it so? Because actually, if you have a diverse mental activity over your whole life, you will certainly deal better with neuronal loss. And actually, a second thing is that you should like diversity in activities. And so the eagerness to have a very various activities in life, like I will tell you what is in this paper. Sports, literature, reading, playing music, learning languages. All this, if you think about that, you just start getting eager to do it very early in life. If you don't learn that at school, you will not learn it at 65. And so I really believe that education will protect your brain for what will happen very late in your life.
But are we really equal in front of this? Because, yes, you say no, obviously, yes. Money and education also, the way you were born, the parents you have can also, and so yes, when you say education at school, that's probably a solution. We addressed that this morning already, but children also taught their parents,
There is a wonderful study, which I always quote, when you actually give to a family $200 more per month, and you actually look what is the outcome of the cognitive, position of their kids after 10 years, you will see, even in the first 2 to 5 years, it just make a big difference.
So $200 a month, that's barely nothing.
In families who have deprived and otherwise couldn't, it's not only food, but allowing people, things like
culture,
and just, meet friends, go to a cinema and things like that. It makes a big difference. So, but this is always, I don't think this is, quoted enough. That is actually our duty to help families when they actually have problems.
It's money. It's also the way you use money. And that's very important for culture. If you think about the way people who don't have that much money, the way they spend that money in activities that will actually let you absolutely not cultured at all, and you know what I think about, like children in front of smartphones for the
we'll talk about that.
Hours and hours.
Don't worry.
And I think also that traditional civilization, traditional cultures actually deal with this problem of feeding children with something. And so the problem is also the way we use money.
Yeah, even when you don't read, actually, even civilization who do not read, they transmit the history like a spoken history, but that's important for the tradition and also for the preservation of
late in life too.
So for those who are not here this morning, probably you are wondering what is this. So we have wonderful sketches and drawing from Mr. Lapin, Monsieur Lapin, actually. Who's super talented too. summarize everything. So I talk, he he draws. And then you can find this on the social medias, of course, and you can share them at the end of these sessions. And now we will move a bit forward, take the next step and focus on research, because that's also very important. Treatment, innovations, that's what probably patients are waiting for and waiting the most for. So Serge Goldman, in your field, AI is, of course, obviously a valuable tool. But in a field like this one, when it comes to brain disorders, there are probably some limits left.
Yes, first of all, just repeat that AI is helpful for research, and it's probably the best way to accumulate, manage, analyze huge amounts of data that we couldn't analyze earlier. So that's the first point. Mm-hmm. Second point, AI is just a way to do better statistics. I mean, it's essentially a statistical tool, and that has some implication. It means, for instance, that statistics will always favor things that you can extract from the data you have, from the experience accumulated. And so if you think about that, there's a problem with creativity, with developing innovative solutions to problems. Because if you just use what you have learned to build something that will be the future of research, it doesn't work. And so the first point is that you need to put human brain within the AI process to maintain this creativity among researchers. And that's a message I would like to transmit, because it's very crucial. I was speaking about chance with this person in front of me, and I said, okay, it's possible to introduce chance, odds, in the AI process. You say, okay, once in a while I put something which is nonsense. And that might be helpful. And that's what we do in research often. But that's not the way it will work, because you need to feed the way the human brain puts creative ideas within a research, not just by playing by chance. So that's my first point. Now the limits, I could spend half an hour on...
We have 80 minutes, so...
I know. The first point is that my first point would be, okay, we need to use AI to play on human health. It makes sense. But it should be used to do something that we don't do for the moment. Bioinformatics, we use that in human health for years. What AI does is what you all know was what ChatGPT does. That means it's the way you deal with semantic information, semantic data. That means you can play with ideas that are produced in a natural language. And the problem with research for human brain is that until now we have just transformed these ideas, the thought, the mind. You know, there are a lot of institutes of brain and mind in the world now, in universities, everywhere. It means that we need these connections between brain and mind. And so we need to use the mind language in AI. And for the moment, we don't do that. What we do is we transform these ideas in numbers, because bioinformatics is extremely efficient to deal with numbers. But now that we have AI, we need to introduce semantic ideas, semantic data within the process. And that's why AI is helpful in my view, because then we will go to precision medicine, to personalized medicine. And personalized medicine for the brain is just introducing the person within the process. And the person is just the mind of the patients. And so that would be the first thing And it's a limit to not just using AI the way we were doing bioinformatics for years before. I have other limits which are ethical, but just
maybe for another debate.
If there are questions about the ethical questions, I will do it.
That's very important, though. That is really important to keep them in mind. Also, these kind of limits. So
okay, so but
short,
just
very short.
Ethics and AI for the brain. First thing, as you know, to have AI on something, you need pathological data, data on patients, neurological or mental disorders, and on normal subjects. So you accumulate a lot of data, which are essentially very personal by definition. And so you need to know how you will deal with this. Second point is that companies involved in AI productions are just having intentions which are not related to healthcare. It's essentially based on other projects in the development of these companies. And so that's the second point. They develop something which is not acceptable, which are based on a black box paradigm. They don't want to have you being able to understand what they are producing. And that's a major issue. And actually the EU has developed a lot of rules to fund, for instance, AI in research, and all those rules, I will not mention all of them, but some of them are very important. You need to be able to explain and to show how you explain what AI is producing. You need to be, there is also a question of responsibility, accountability. If you produce an AI product that is harmful, you need to be responsible for it.
I see Kevin Rustasi, and I know that at your hospital you work a lot with AI. There is a department on that. I see you nodding, maybe.
I want to, but not yet.
Not yet. Ah, sorry.
Just imagine a patient with multiple sclerosis. Usually you count numbers. And if a company, for example, says, this is the best way to deal with the disease, that's just wrong. That's a very good example of how a intention of a product goes wrong. Because there's a process that starts with a neurodegenerative component where numbers of lesions are nothing. So there are many other aspects come into this technology, and nice to hear that there are some rules.
Yeah. Just before we move to treatments, I would like to hear you on these new topics of research. So you already talked about that, you mentioned the problem with new addictions. We have these young people, also elderly, older people, not only young people who are addicted. These have emerged from the past few years, social networks, gaming, electronic devices addiction, and that is a major concern for brain health also.
Yes, I must say I'm not a psychiatrist in children, but the department is 100 yards away. They have established a whole unit on children who have gaming addiction, and they do game 14, 16 hours. It's a huge problem, especially during the COVID pandemic. It has increased dramatically. I would like, probably we come to this later, but I want to shift a little bit to screen addiction time.
Yes, no, go ahead.
Can I?
Of course.
Because that is very relevant. We have a dramatic increase of children who are declared as autism between the age 1 to 4. And it's really, really dramatic. First, we have no institutions to look after these children. And it is sometimes difficult to separate from true autism. And so, meanwhile, there's the assumption that if you have somebody who has a trait and you put him in front of a television or a screen, you will produce actually the full set of an autistic spectrum diseased child, which might be reversible, but we don't know. And it is the data say 1 in 40 children will have an autistic phenotype and needs to be evaluated, and that this is increasing to 1 in 30. So that's really dramatic, because for the whole society, you cannot accommodate for that. That costs so much daily, as I learned, in the long term. These are 4-year-old kids going up to 80.
Mm-hmm.
I think that's a real drama.
And in addition, there is a push. We have a section of autism spectrum disorder, but in adults, sort in old age, sort of not kids. And it's quite interesting that we have a large queue of people who want to have the diagnosis of autism. It's at the moment chic, you see, because they think that these are specifically smart people, which I think is one of those myths which is put forward. But I think it's a big problem that we are not dealing with that, you know, like we had other sort of waves, but this is one now, and we need to tackle that. But coming back to the addiction, the internet addiction, that it's an issue, and as you said, not only in kids, but especially in adults. But having said that, you know, if the brain is immature and sitting in front of whatever for 10 hours, 12 hours, there is no real good and healthy development. So that is something we need to take into account. But again, what we need is early diagnosis. So, because a lot of kids, they will, you know, stay in front of their TV whatsoever for 5 hours, but they do football and they go out and have friends and things like that. So that's fine, you know, but it's, you know, to have the boundary there. And if there is a problem, then treat adequately and quickly.
Maybe what we can also mention, and that comes from the study on the first 1,000 days in life, is that not only really being on the tablet and on the phone and watching it, and also the TV is important. If you have a TV always on in a room and that the child is there, the effect is the same, actually. Mm-hmm. Who here is an adult? I think everyone. And who spends more than 3 hours a day on the cell phone?
Oh, sure.
Hey, go ahead, guys. I'm the one. Just only that? Okay, fine. We are safe here. We are safe. Are we honest? I don't know, but we are safe. And so, Peter Falkay, in the last few months, several drugs have been launched on the market, and they treat schizophrenia and dementia. This is, of course, positive news, but these drugs doesn't apply to all the patients.
Well, but I mean, I think it is a big advancement. I mean, think about, for last 15 years, we had sort of minute differences in developing antipsychotics. Now with Cobenfy, that's KXT, that's a new drug for psychosis. And I think this is a big development. The other thing is, I mean, think about Alzheimer's disease. I mean, that was described by Alois Alzheimer 110 years ago, right? And what did we do? Nothing. I mean, there was no cure for this illness. We just, you know, we just accompanied people more or less. And now, for the first time, we opened the door to a, as I say, disease-modulating therapy. I know that there is a lot of pros and cons, but at least we start. So I would say it's a big advantage, and you know, we need to learn. But you see, it's like when antipsychotics in the 50s were introduced, we need to learn to whom, what dosage and how, and now it is part of our treatment. So I would say that, you know, we need to learn Cobenfy, you know, for what, for whom of the patients is that best suited. And it's like with lecanemab for dementia. So I think it's a big success, and I'm really waiting forward. At the moment, there are several new drugs, you know, in phase 3, so hopefully they survive phase 3. And then we will have more possibilities and choices in mental illness.
Serge Goldman, you talked about personalized medicine, and it's actually what we are going to address. With this kind of drugs, probably they are not made for everyone, but they can help the people that are really in need of these drugs. So that's important to identify clusters of patients.
Yes, that's important to understand that it's related to the AI question in a certain way. And it's the introduction of what we call system biology approach that are biostatistical too. And the idea is just to gather information, data on the patients in such an amount and in such a variety, including any kind of what we call omics data about the genome of the patients, but also their biology, their metabolism, whatever you can accumulate as data on these patients, and to analyze that in such a way that you can classify the patient not just based on the symptoms, but based on the clustering, the appearance of various changes that are common to a certain category of patients who certainly will respond differently to different drugs. So until now, okay, we based the therapy on the symptoms, so we decide this patient has that disease, like Alzheimer, schizophrenia. And then we play with drugs. We give one, it doesn't work, we give a second one, we add a third one, we stop that one because you get side effects. And so you play, and you don't really know why that person just behaved that way in front of this. And so the change is just to start differently. I just accumulate whatever I can to identify what will characterize the response of that patient to that drug or that type of therapeutic intervention. And again, I will say one thing. Within this, we need to introduce personalized data. That means including aspect of their mind and not just accumulating genetic information, metabolic, biologic, and whatever you can. I will also insist on the second aspect, which is what I've been working on for years, which is connectomics. That is the way the brain actually works as a networking machine, and the way those networks across the whole brain might be disturbed in some disease, and you can acquire a lot of information and a better way of classifying patients, including with Alzheimer, actually. If you look at the way the brain is working that way, and that's my feeling about the clustering of patients to choose the best therapy.
Not only in Alzheimer, but in
other
severe mental disorder. Yeah, connectomics is the future. I understand, not only how brain regions are connected, but what is the function to that. So there are big networks which have specific functions like the default network, default mode network, and others. And I just wanted to complement that. So that's, I think, an important area of research. And as you say, AI defines subgroups with mechanisms and then do mechanistic, let's say, based treatments. That is really the future. And for that, we need AI.
Is there any concern from the patients to give their data to AI? No. Even in your field, there's no concern.
You see, this is typical.
Because it's more personal.
People, they're all difficult. They're not difficult. They're not different from other people.
Of course not.
Well,
no, I mean, it's just that it is so personal what you have to say to a psychiatrist.
Yeah, I mean, we have done studies on that, and 80% of the patients coming into our hospital, they are fine. They're giving their data, their personal data, to research. And we have looked with colleagues, and that 80% seem to be the maximum you can reach. So actually, I think that most people who have an illness, mental or somatic, I mean, they have suffering. So for them, I think it's important that they see there is progress. So with that background, a lot of people will say, fine. There are people who have their problems with that, but they're fine. So we say, no, we don't take your data. You can be on the sure side.
Yes.
Just to follow on this, I fully agree with you, but the problem is that to do AI studies about the question we are dealing today, you need to accumulate a lot of the data. You actually accumulate a lot of data from subjects who do not know that you are accumulating data on their life. And that's the problem. The problem is the consent. I fully agree with you. If you ask a patient to provide data to improve health for them and for anybody, they will
just ask
give it.
The subject.
But the problem is that for the moment you read, when you read 5 pages about the conditions you need to agree on to enter in that activity on the internet, you don't read it. So in a certain way, you approve things that you don't know, that you don't understand, that you don't read. So the real problem is that AI is built on huge amount of data that are circulating on internet and for which you never ask any kind of consent to anybody to play with them in order to better understand the human mind and the human brain health. And that's the real question that you ask to my colleague.
Yes, go ahead.
You can answer.
Yes, of course. Go.
Well, I mean, it took us 2 years to have a broad consent for the patients. Now we have one, and that includes all different issues. You know that your personal data. You know that we like to do research on. You know that we might send it and exchanges with other research groups. I do take your point, but on the other hand, I think that is relatively safe because, as I said, 80% of the patients are fine. 20% will say, even after the second question, no way. But I think that, having a family where we have mental illness in my own family, I would say, yes, I would sort of support the notion that these people give their data to research because it's not absolutely safe, but it's as safe as we can make it.
We have a question here. Yes, go ahead.
Yes, hello, my name is Sven Arts. I'm from the 1400 Medical Spas, and I want to come back to the topic that was raised on AI and data. We have all seen the spectacular YouTube videos on that lady that was completely locked in, and then there was a device planted into her brain so that her brain waves could be read. And then the AI was capable of understanding from the brain waves what this lady wanted to speak out. Where are we in, for example, when I go back to the heart, for example, it's and then you have an electrocardiogram, you see all these waves. The heart is compared to the brain, of course, much simpler. But where are we with all these dry EEG sensors, for example, that we can put on the scalp? And what kind of, and then you have all these waves from the EEG. But now finally we have AI that can help to quickly read through all these EEG waves. How far are we with AI to interpret these waves in helping to speed up the diagnosis? For example, diagnosis for children with ADHD, for example, it takes like 14 hours and very in-depth interviews with just about everybody. With this AI, this could be reduced in a matter of hours, for example. How far are we on that? Thank you.
Well, HTH and HEHD, I think, and autism, I think we're on a good way. I know because we have those issues, we have projects in our department. But the question is that, to have a first step, just to give as a rule of thumb, you are fine, there don't need to be more detailed analysis. But at the moment we are not able, and I'm not for the foreseeing time that we will make up the diagnosis of ASD on a proper way, for instance, or ADH with just using AI. Maybe just one word about, clinical data compared to biological data. I personally think that at the moment, using clinical data will be much more easy for us to predict. Using genetic data, imaging data at the moment is much more difficult. Maybe that's some positive aspect. So we will use, and we currently use clinical data, for instance, at our clinic, in order to support the diagnostic process.
I have a question coming from internet. What are your thoughts on sharing data in the European health data space? How would you convince citizens to share their data? Not all of them are patients, and that's exactly what you said. What about people who are not patients?
I think just read what EU asks to follow as rules. The first thing is that you need to be sure, to ensure that the use of it has good intention. That's the main point. Any citizen in the world would accept to have his personal data used if the intention behind what you will do with it.
You mean no insurance companies going into?
And that's the main point. And I think you need to convince them by changing the way AI is developed and protected for the moment. So at this stage, I think I fully understand that citizens would refuse it. And I just invite all of you to read those rules that are easily found on the internet. That has been a very nice work done by Europe in comparison to what has been done.
NIS2.
All those rules that Europe is asking to be followed when it deals with using AI, in particular, if you will have influence on human life. There are a lot of things, and when you read these rules, and if you are sure that they are followed, I'm pretty sure that any citizen would accept his personal data to be used to improve health.
Mm-hmm. Kevin Rustasi, you advocate for equitable access to the highest standard of... you have something to add. You do not hear me. I will speak louder. So you advocate for equitable access to the highest standard of patient care in urology for children. What is the state of play at the moment? Is medicine or drugs accessible to everyone? Because we hear that new drugs in some diseases are very, very expensive. Is it the case in your field?
Yes, but I have to state actually, I think what happened in the last 10 years in regards to expensive drugs and the availability, I mean, that's a tremendous success story actually in pediatric neurology. Mm. I can treat now children with MS when they're 6 years old, up to 18, even with controlled trials like fingolimod that has not exists since 5 years. And also in many neurodegenerative diseases or spinal muscular atrophy, Duchenne, they developed at a speed unimaginable very effective therapies. And interestingly, many people get these therapies. It will become more and more difficult to very rare diseases, like, for example, to say one, NCL3, which is a disease affecting the eyes, and dementia, of which there are, for example, 20 patients in Germany. No drug company ever will develop a medication. But there are startups, for example, who developed an antisense nucleide just for this disease. So who's giving this medication to the patient? This is a very big problem. It is not covered by any insurance. It's not covered by any study. And this will emerge for many diseases in the upcoming years. Mm-hmm. There are initiatives, for example, in the Netherlands, the N1 project, which might help in organizing these patients and collecting all these data. But overall, I think, especially in pediatric neurology, that has been a big success story. And I only can tell you, this is always, I like to make this political remark, that my organization not only covers 28 member states, I think that's the EU, mm-hmm. We have 44 members. Where do they come from? Kazakhstan, Turkmenistan, Mongolia. They are all interested in our setup. And I think this is a very, never know the English word, Blaupause. It's a very good blueprint. It's a blueprint, and it's many countries would like to have it that way.
But don't you think that that is the future? I mean, you see, we have about a third of patients, for instance, with depression. They do not respond, whatever you do. You end up with about 10% of all patients with depression. They don't respond to anything. And I think, you know, we should genotype these people and, you know, possibly have CNV or any, you know, genetic abnormality, and then design with a startup drugs which actually help these people. So I think you're right. It's very expensive, but I think you and your discipline has shown the way forward to actually deal with rare circumstances of disorders.
So
personalized medicine, huh? It is personalized medicine.
At its best, yes.
So I would like to say a bit more actually on this economic side of the disease and of brain disease. Brain disorders are an economic burden, and let me be clear, as every other disease. That is exactly the same. However, you all have the feeling that the budget allocated are still largely insufficient. We heard this morning from the Commission that there are some changes that will be implemented, but I see you, I see your face, you are not that convinced. And I'd like to hear each of you on the challenges. So first of all, Serge Goman, you think that this is not going to be enough?
No, just because you need to think about neurodegenerative disorders. You know, I remember this 15 years ago, Standard & Poor's, the credit rate agency, warned the whole world that it will be unbearable to support the cost of dementia in, let's say, 10, 20 years from now. It's not that far.
Yeah.
And so it's a little bit like climate in a certain way. We had to wait for fires in the Colorado, floods in Europe and anywhere in Asia, to really realize what's happening. And in a certain way, it's the same with the difficulties we will have to deal with aging and dementia. Remember what happened during the COVID story. We then realized we are not able to deal with the institutions where all those demented patients are maintained. And it's funny, it has something to do with climate too, because every summer, you have these numbers of people, demented people that nobody can take care of and who will die. So everything is combined. That's the One Health story about the interactions between all the effects. And economy needs to understand that they will have to deal with this huge problem of neurodegeneration very fast. It will be in a few years that we will realize that it's not working well. And you know, the amount of money, I just went back to the numbers, it's let's say 3-4 trillions of euros for the moment. But in 2050, it will be something like 70 trillions. So that's not possible for us to deal with this if you don't apply very simple measures. It's not expensive drugs. It's what we already said. Education, again, education.
Again and again.
Social interactions that you need to develop. That's essential to maintain, to deal with the cognitive decline.
It also takes to change the mindset of the people, maybe
Absolutely.
in the society we are.
It doesn't cost that much to reduce a lot of this burden of dementia. And I just list of them. You know, hearing and visual loss, that's a major issue for the cognitive decline. It's very easy to detect, and nowadays, very easy to improve. Why don't we put a lot of efforts in this? And no, you have traumatic brain injury. We are back to the disasters question, but the influence of this on neurodegeneration now is understood. And so that everything you see, obesity, smoking, I already said, I think, those are so easy to improve that I don't understand why we are not starting doing it.
Maybe
we are humans.
because we are humans, or maybe because this doesn't follow, you know, the scale of going to the first doctor you see? Maybe the first doctor people address to is not...
You know, it doesn't hurt, but you see, I think there are two things. There's lack of information. I think for a long time people didn't know if you don't have a hearing help, you know, it will increase your likeliness to become demented by 13%.
Yes.
That's increased now with it's about 30 to 50% of the risk to develop dementia can be reduced with environmental changes, which is quite remarkable for a disease where we think it's like a machinery that just go downhill, but there has been someone.
Yes. And wait, because the microphone is there, Delphine, and then we'll... there is already someone with a microphone in their hand. Yes, I see you.
So
if you stand up, we can see you, because otherwise we do not see you.
I hope I'm not in front of the camera.
Yes, thank you.
So, I had a question before, and I'm actually going to go back a bit on everything you've just been talking about. So I hear lots about we need to acquire data again. You know, we've also heard that this morning. We need to reuse that for research. We need to do a lot of research on it. So I've also been very active in the rare disease research, in where you indeed need all this data, because this data is everywhere, because there are not many people around. But these people also need that data again to go to the clinic. So basically, what I'm also advocating for, and I'd like to hear your opinion about it, is, you know, giving back the data to the people so they can go around. You know, we have a freedom of movement in the EU, so why not the freedom of movement of data, so they can take it with them. You can also using data visiting to train your AI models, which has been validated a couple of times. So what's your position on that?
Anyone?
I never thought about that, but I very good idea, actually.
Yeah, I mean, we have what you say, we call this sort of flexible broad consent. So actually that it's not a broad consent for your life, but actually, let's say for every study, you just get an email and say, do you consent? And in addition, you get your data back. You can use it, you know, for clinical use in addition.
Yeah, indeed, but that's called dynamic consent, right? That's not called...
Dynamic, yes.
Yeah, yeah, okay. Yeah, no, then we're on the same page, yeah, indeed. So using dynamic consent, going back to the person, requesting, can I maybe reuse your data again for this purpose? So that also this person can at some point, because the issue with broad consent is, I can never go back. So if you do not agree with what I'm researching, I will never know. And you will never be able to say no to this research question. So indeed, dynamic consent is, I think, one of the basic principles that also is implied by GDPR, etc.
Thank you. We need a microphone here for Delphine.
Vanessa, I will just explain a bit better the real problem. You know, a few years ago, something like 10 years ago, before we had the word AI, people said, okay, if you take billions of interactions by email, you will determine who will have cancer in the next 5 years. Just by reading what this person is putting in his email. So the real problem is this. It's the fact that we are not dealing with information which belongs to patients. The problem is that now it's information wherever you are and wherever it's produced. And that's a real problem, because for this we don't have consent. So the only problem is to have beneficial use of what's happening. And so it's a real philosophical problem. It's not a practical. I've been for 30 years on an ethics committee. So I've seen this evolution of what we call a consent. I fully agree with you about the way we need these dynamic aspects. And actually we implemented that in my institution. But the real problem is not there. So certainly if you have emails from people, you will determine quite easily who is depressed, who is perhaps schizophrenic, and who is developing Alzheimer, or who will have Alzheimer in about for 5 years. That's the real problem. Do we want this? Yes. If the intention is to improve health, if the intention is to improve the way insurances companies are dealing with citizens, then we will not approve that. And just to give you an example of where the real problem is, the intention.
Delphine.
Yes, I really would like to thank you for the very interesting debates and questions raised, completely outside of my comfort zone. But one thing that strikes me is a great deal of dimensions of what you've been talking about is very political. And you're all researchers. To a certain extent, you're heading scientific society, which is a first half step towards politics. But wouldn't it be time to consider to have actually professional lobbyists in your organizations? It feels that the struggle is not on equal footing between commercial companies and scientific societies. And it's really something I would like to hear your opinion about.
100% agreed. So my society, the German Society of Psychiatry, where I was president in 2010 and 11, they have built up a whole division of 5 people. They don't do anything else, just to try to interact with politics. And as you know, in the beginning of next year, we will have elections again, and they're trying very hard to put in, certain, like prevention of suicidality and things like that into the agreement between the parties. And they were quite successful, but I completely agreed. I think you need to have that.
I think there is someone just behind you. Thank you.
Hi, Mauro Placchi. There are 2 things that have not emerged. First of all, did you realize that 75% of the latest application approved by the FDA related to MRI reading automatically through AI? So also this implies that also this kind of assessment will be extremely facilitated, and it is not the end of the story. Because if you realize in dementia, for instance, the number of biomarkers other than the tau that are emerging associated with a variant of the dementia. And that is causing a lot of cost, particularly to central laboratory testing, because every 6 months, this kind of huge corporations have to change the testing, which implies hiring PhD, specialized people and else, in order to make sure that really you are effectively applying the precision medicine.
Agreed. I mean, that was one of the 2 points I've written down. I wrote down, help us with research and care, reduce routine, burden of routine.
There's another question. Go ahead.
Hi, can you hear me? Yes. Hi, I would like to ask a panel about the prevention, and we've talked earlier about preventative strategies, and you mentioned a couple of times today Lancet Commission, which identified the modifiable factors in dementia. We've talked about education, but I haven't heard much about education about brain health. And to what
about brain
education about brain health, and to what extent we're teaching younger generation about brain health. My son knows very little about brain health. He's 15, and he knows very little about whole foods.
I think the short answer is it is not existent in many. Yeah.
And when we talk about huge bills that the European nations will be paying for not investing in brain health, I was just wondering to what extent the public health organizations at the EU level are doing anything to promote brain health, to educate populations, to know what it is. That dementia is not something that appears at 65. But basically your lifestyle in your 40s will lead you to your 65 symptoms of dementia. And I just, I think it's really, I think it's very urgent that we talk about brain health. Education is fine. We're all here today. We're super educated. We know what we're talking about. We absolutely understand where we are. But I don't think that even in this audience today, everybody knows enough about brain health. I don't know as much as I need to know, but I try to follow what is being promoted. I try to follow initiatives at the EU level, campaigns, but these are very, very hard to come by. The brain health is very much politicized. It's very much driven by pharmaceuticals. And we're talking about things that we're talking about a brain health disease, but brain health in itself, it could be very positive. We could be talking about neurogenesis, creating new brain cells if you exercise enough, if you eat well. We could be talking about neuroplasticity. At my age, I'm able to create new connections. So anyway,
yes,
my point was
I heard the beginning of the answer. So
I think
you said that's my research.
we need more
so maybe you will have an answer here.
Brain health education. I think that's my message.
My research is the influence of exercise on the brain in mental illness, but I mean education is maybe you want to
Yes, I think both of you. Huh?
No, I can only say that through the iGap initiative, many countries, all countries in Europe are mandated to have at least one campaign in regards to a brain health aspect. For example, in Germany, I know that there will be a concussion day initiated by the young pediatrician, pediatric neurologists, to bring awareness of what concussion means in the long term for children 5, 6, 10 years old. And I guess it's a slow process, but for example, looking at the United States, where my daughter lives and her son plays soccer without using the head, but he's not allowed to play football anymore because it's in the general consensus that football is bad for your brain, and that will change to some degree the sportive reality in the United States. I'm pretty sure. So there is slowly setting in that the brain, that's the most valuable organ you have, by far.
And it's just fascinating that people are not interested more. It's just why? We're interested in heart, in kidneys, in lungs, but when it comes to brain, it's just there is something there that we should really have a public opinion survey to see what it is that's stopping us from.
If I can just answer this. Again, it's a question of education and culture. I think that it's said, and it's probably true, that the brain is the most complex object in the universe. If you explain that to children, they will start being interested in what is the brain. So the problem is not educating people about brain health. It's a question of interesting them to the object, the brain. And there have been some brain awareness, brain decade, for instance, in the US, to have people showing brains in schools, and then they will understand why brain health is important. The first thing is to have a cultural influence of them, not just providing data about how you should, what should be your diet. You need to do sport because I agree, it's true. And I already said that sport is important, but it's not giving new rules. We have enough rules. First thing is to increase the interest for the project and for the idea. And that's my guess for having a better approach of brain health in the population.
I would like to keep going on innovation and treatments. There is one thing that would probably be helped if you had, because I'm not doing anything, if you had more funding for research. Yes, I'm not researching anything actually. And it would probably be drug repurposing. Is it something that we should lead as a path?
I would immediately agree, because I mean, to people who don't know that, it means that there are drugs available which are actually taken by human beings, so have been approved, and you change the indication. So for instance, we at the moment study a drug called clemastine, which is actually an anti-allergic, but it was found out that it actually helps the myelin regeneration, sort of connectivity, so that's connectome we learned about. And the hypothesis is that with improving the connectivity again, it will reduce dyscognition and negative symptoms in schizophrenia, and that's why that would be actually a causal treatment, right? Because it wouldn't be going with antipsychotics, just dampening the whole brain, but it would actually help the brain to regenerate. This is what you call repurposing, take another. I personally think that is a way, but we shouldn't forget that possibly we need new drugs by a new mechanism. So repurposing is one answer, but I think we shouldn't forget we need money for basic research, because our knowledge, for instance, on mental disorders is very small. But we need, I mean, look at oncology, you know? That's a beautiful example how they approached and improved their treatments, because they understand sort of certain types of tumors, and with that they can actually offer causal treatments. That is not the case in mental disorders, most of the mental disorders. There are exceptions, but you know, most of them. So we need to have mechanistic understanding. For that we need money for basic research. A lot of people think, well, it's not a good idea, we should do clinical studies. And I said, yes, but what on? You know, use the old drugs and do clinical studies, that's not the way. You need to have new knowledge and then have mechanistically informed drugs.
Serge Goldman?
I fully agree with you. I think that repurposing means that we need to get knowledge about the disease. That's the point. Then you can repurpose a drug that you have. For instance, you think about the relationship between inflammation and brain disorders. We now understand how important it is, including for mental disorders, including for Alzheimer's disease, for which you have an implication of inflammatory process, which are certainly extremely important. And then we realize that we have the drugs playing on inflammation, and we have immunologists who are extremely competent in playing with those drugs, and we don't do it. And so that's what is missing is knowledge, increase of knowledge, and increase of basic knowledge, which is what you said, but also non-target research. Because if you just think, okay, we will deal with Alzheimer's and we concentrate on this and we have a very large view on this, okay, that's fine. But that's not sufficient. We also need non-target research, because that's the way we are back to the creativity questions. That's the way serendipity will actually provide you something which is really new, which is the real innovation, not the one you have tried to catch. And so put money on that non-target, what we call fundamental research, but I would prefer to use the term non-target research. That's absolutely essential to improve human health, in my view.
Mm-hmm. We have a question there. This will be the last question, and I will ask you to have a quick question, if you can.
Okay, hi, I'm from ADHD Europe. First of all, I just wanted to let you know that our patients' organisations across Europe, we use the strength-based approach for early intervention. Our members are the ones going to the schools. We are the ones training the parents. We are the ones educating the schools and the teachers with no government support. We are doing the government's work. We are involved in research projects. We know how the brain works. We know about the genetics. We know about the overlaps of the cardiac, the insulin, all the somatic diseases. All these research projects going on. People aren't talking to each other. It's all connected with the brain. The Commission's giving so much money out there, billions of euros, and nobody's connecting the research. That is the key. We're watching this on the ground. So I ask you, all of you neuroscientists, all of you researchers, all of you from universities, talk to everybody, get the information, put it together, because the economic burden, it's a lot. Not only do we need the education, we need the health. We need better lives. So one of my questions is, Sorry, I had to write it down because I've got ADHD and I have a bad working memory sometimes.
So just one question, if you don't mind, because we have to...
So with all the health systems being different in each EU country, when is the Commission going to understand that education and health need to be on EU level, not on national level? Because each national country needs help. So who's going to do it and how is it going to be done? Because we can't say when. It's who is going to do it and how are you going to do it? Because that's what we need as patients and people.
Thank you.
Thank you.
Who's going to answer this question?
I can tackle it. Medicine and projects are evolving, but for example, for the EPNS, I can say that most projects that are launched in the recent years include patient organizations. There is no project anymore going on without patient input. And so I hope this will lead then to more satisfaction on your side. But I think it's also mandatory that the patient perspective or family perspective needs to come more into the game. And I fully agree, it needs to be on EU level, but the national then have to adapt it to their societies.
Thank you. Sorry, I saw that there was one question in the audience, but I won't take it. We have to move forward and to move to the next session. Thank you so much for this fruitful conversation. Thank you so much. We have a coffee break. I'm sorry. Let's have a drink, a healthy drink. This is going to be in the Marble Room. 15 minutes. Yes, supporting mental health. 15 minutes? 20? Half an hour? Half an hour. Ok, on va prendre la cloche de Georges Casimir et on va les appeler. Georges Casimir, il a une cloche. On passe dans la salle. Ting, 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 ting. Merci beaucoup. Hein. Ah ouais, très chouette. 3h50. Oui? Thank you. I didn't know that they were. Should we start? Yes, we do. According to the WHO region, a European region, every day 1,000 children are diagnosed with cancer. Nowadays, thanks to the innovative technologies and improved diagnosis and treatment, up to 80% of childhood cancer can be cured. That's what we heard from this morning with Delphine Hennen. In Europe, more than 500,000 people are considered survivors, childhood cancer survivors. So the disease can still affect them in the long-term health, well-being, mental health, and job opportunities. To address these challenges, we will have several panelists, but we will start with two of them, Karina Schneider and Dr. Ulrike Leis. Please come on stage, and I will introduce you to the audience. They will start with a keynote speech, actually, to give us some key elements on survivorship. So thank you. So Ulrike Leis, you are a clinical neuropsychologist and researcher at the Department of Pediatric Neuro-Oncology at the Medical University of Vienna. Thank you for being here. And Karina Schneider, you are a psychologist, you work in pediatric oncology, you are a patient expert and the managing director of CCI Europe. And what we will see after, and that will be very interesting, that's why I'm actually pointing it out, after surviving a cancer, you experienced the lack of adequate long-term follow-up of care and became an active patient advocacy. And I would leave the floor to you, ladies, so that you can tell us more about survivorship.
Thank you very much for the kind introduction, Vanessa, and thank you everyone for still being here after what has been a very, very inspiring and interesting conference day so far. So today we are talking about survival, and also about changing the paradigm of how we look at quality of life in pediatric cancer. So just a very few to give the context about Childhood Cancer International Europe. So we are the European branch of a global NGO, non-profit organization that is parent and survivor driven, that has been founded in 1994, so 30 years ago. And in Europe, we currently have 64 member organizations across 35 European countries. And as Delphine already pointed out this morning, so we are speaking about the geographical Europe and not only, sorry, the political EU. So, childhood cancer in a nutshell. So I think not everyone was here this morning when Delphine already set the stage and gave the frame. So just briefly to recap. So in Europe, again, geographical Europe, we have 35,000 new cases of pediatric cancer each year, and still 6,000 of these young patients will die. Pediatric cancer is still the first cause of death by disease in children that are plus 1 year of age. Thanks to, and this is what Vanessa already pointed out, to the progress in research, approximately 80% of these young patients survive in Europe, which leaves us today at approximately 500,000 survivors of childhood cancer in Europe. And this number is luckily growing. However, because the treatments that on the one hand bring this big success in survival rates are also highly toxic, we are looking at 75% and probably even more who are facing long-term side effects or late effects of their cancer and their treatment. And this includes physical late effects. It can address any organ. We have a lot when we are looking at cardiac issues, endocrine, orthopedic, for instance, if you have had an amputation, for instance, or a prosthesis, as well as psychosocial late effects. This can be post-traumatic stress, it can be depression, anxiety, isolation, body image issues. And many of these young cancer survivors are poorly informed about these late health risks. And this, again, poses an additional layer of risk for them in their future health. And at the same time, we have a significant lack of support, so psychosocial support, but also follow-up care structures to help manage these late effects in these young patients. So I will now go a bit more on the personal side today. So I think this is something that we need to bear in mind as a community always. Cure is not enough if we look at these outcomes. So I was diagnosed with a Ewing sarcoma, which is a very aggressive cancer of the bones when I was 17 years old. So I was, in the year before graduating high school and so on. And I really wasn't so aware of cancer in children. Usually you hear about, grandmother or aunt or uncle who has been diagnosed with cancer, but rarely you hear it from your peers or in children, because also, as Delphine pointed out, pediatric cancer is rare and ultra rare. So you are not so easy to find a fellow cancer patient in your vicinity. So I received this diagnosis, and then I went in after, of course, shock moment, no question about that, right into survival mode. Okay, so you pull yourself together and you do this, and everybody says, okay, so this is about a year of chemotherapy, radiation, surgery, etc., and then you can go back to your normal life and go back to school, see your friends. So that's what you try. So after this year, luckily for me, after this 1 year, oncologically it was done. And then I tried to go back to my normal life. Just that it didn't work because the normal life wasn't there anymore. Because you have undergone trauma, period. You have undergone many, many invasive procedures. You have faced your own mortality at a very young age, which isn't supposed to be at that age. You have been torn from your social network, from your friends. Also, your whole family's life has been turned upside down. Then also you come back and your social network, even though your friends might still be there for you, but they have moved on. They have had a year in school, they have had a year of partying, like in my age at least, so maybe not so much for the younger children. And also you have changed. So your body has changed for sure, but also your emotional, the way how you emotionally experience things has changed. So it's not, so the normal life just isn't there anymore. But then there is societal expectations that are being thrown at you, and this sounds so negative, which this isn't, because everybody is just so happy that you made it through and that you have overcome. And so how can you not be happy that you have overcome all of this? But then here you are very confused, like speaking for many adolescents at that age. I think you are anyway in a weird physical state. So your body, you know, you're growing, blah, 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 I don't need, so we've all been there. So very awkward. And then you experience such a critical life event. You're confused. You have physical scars. I have my whole leg is one, looks like a battlefield. You have emotional scars. And you have very strange body sensations during treatment, but also after. It doesn't just go away like that. So, for instance, I experienced months of hot flashes, which usually women have in their menopause. But you don't know what that is. You don't know where it comes from. It's just all blah. And then you also experience anxiety, because you don't know, will it come back? Do I have to go through this again? Will I be diagnosed with even maybe another cancer? Because if I had it once, who can tell me that I mean, as we all know, that you can also have it twice. And then you are also awkward a bit, so you maybe have social anxiety, you have been rather isolated during the treatment, and then you see that your peers feel so different from what you are doing. Again, they have been partying, they have been going out, becoming independent, and you don't click with them anymore. So where does that come from? So you maybe don't meet with them as much anymore as you did before, and this leads to isolation. Then you also might still suffer from chemo brain, speaking about brain health. So your brain is in that foggy state. You are maybe prone to forgetting more things than you did before. You may experience fatigue and just not have the energy to do and to perform as you used to. And so you are in this very strange state. And I, for instance, I could not comprehend what was happening to me, because after all, I should be happy and lucky that I live, but I wasn't. And the thing is that many of these things, most of these things, are not addressed properly at follow-up care, because this is a very nasty assumption, they are not oncologically relevant anymore. So if I'm in pain because whatever my titanium screws are causing me pain, okay, well, so be it, you are alive. Things like that. So, and these are things that very, very much impact your daily quality of life. But you don't have the proper support system to help you carry all of this. Until I met others. So I met other survivors, and two of those very important people are also here today. And then you start exchanging, and then you see, okay, I'm not the only one, I'm not alone. So you all of a sudden see other people who really seem to have experienced similar things, if not the same. Then you meet other people who have completely even different late effects. So thinking about brain tumor survivors, for instance. So different ones, but also similar ones. And there were so many, and still are, so many survivors who were not receiving the adequate support and care for these very, very quality of life reducing factors. And then I studied psychology and started doing some literature research for my thesis on psychosocial care in pediatric oncology. And I couldn't believe how, and this is about 12 years ago, and I couldn't believe how hard it was to find literature that very specifically dealt with this topic. And then these papers that I did found were not reflecting what we could then see in our big European community, and it's also not reflecting what we can still now see in our very big European survivors community. And I was thinking, what is that? So, and for sure, one thing is still back then still not, but a bit more today than it was before, not enough research on psychosocial care and mental health is being carried on in pediatric oncology. And the other thing is, what are they looking at? So, are they looking at major depression? Are they looking at full-blown post-traumatic stress disorder? Are they looking at suicidality? Are they looking at anxiety disorders? I wouldn't have popped up or flagged red if I had been tested for PTSD, because I absolutely did not have some of the key features that classifies post-traumatic stress disorder. But yet I did experience post-traumatic stress symptoms that heavily impacted my life. And so I couldn't believe how this could not be reflected in research and in the studies. And so the question is that we are raising today, and maybe we have some of the answers to them. Which questions, and this is something that we as scientific community need to think about, which questions are we asking? And which questions are we asking to those who we are asking? And how do we make sure to ask the actually relevant questions to these people? And yeah, maybe let's look into this a bit more, because we cannot find the right solutions if we are looking at the wrong problems. So I will move on now to a project that Sandra Gallina has mentioned this morning in her opening remarks, which we are very proud of to be the coordinators. So the European Network of Youth Cancer Survivors, EU4Health. This is a project that is solely led by patient advocates. So together with other patient organizations, we have been writing the proposals. We have been defining the questions that we want to address in this project together with our partners from academia. And so we have, because we thought, okay, well, we need to look at these issues from the patient perspective. So I will not go into too much details. So we do have an interactive network platform, also with a resource hub. So if you go to beatcancer.eu, you can check all of that out. Then we had a work package specifically for quality of life. This is what Ulrike will talk a bit more in a minute. Then we have a work package about the care for adolescents and young adults, which are a very specific population within our pediatric cancer world, but also beyond pediatric cancer. Then we have been looking at equality, diversity, and inclusion, and of course, communication dissemination. So, and with this, I will hand over to Ulrike.
Thank you so much, Karina. And it's just, yeah, we want to present only really some parts of the project, which can very easily underline, I think, what you just told us, because this was really the spirit of the project, what we wanted to do. So what we want to show you just for a few minutes is are the results of our online survey we did. We really wanted to better understand what is going on. And this is really, you already mentioned it, every step we did together. So the lead was really the patient organizations. This is really also, we noticed, and of course in all that discussions we had with institutions and so on, this was really not the traditional way of the research we are used to. But we really, it's not, the project is not over, but already now we can tell that there was so much benefit doing it in this direction. So also for the survey, we really did a co-design and we analyzed the data together, and we had so much. Of course, we looked at all the evidence out there. So of course we did systematic review of literature and so on. But then we had many consensus groups with healthcare professionals of many disciplines, and also patient advocates and parents. And we decided over the questions we wanted to ask. And I can tell you, because of course we know that there have been other surveys out there before, but we really had different kind of questions in there. We asked other questions, additional topics, I would say, and I hope it was closer to the needs. In the end, we had 195 participants from 24 countries. it was still not easy for the participants to answer the survey, we have to admit, because there's still, and we will discuss this later on, I think, there's still this stigma around mental health. So it's not so easy to answer it, we have to be aware. Yeah, and you can see here participants really getting treatment between 1967 and 2023 with different cancer types. And also, interestingly, what you can see here, only around 52% told us they received long-term follow-up care, not only for mental health, all the long-term follow-up care in the past, and only 40% told us, at the moment, I'm receiving long-term follow-up care. And I just want to point out some of our results, dramatic results, I would say. So we do have guidelines by now, because we do have some, we do have research around it and so on. And for example, regarding long-term follow-up care, we know, and the recommendation are very clear, also for mental health. So the recommendation would be at every follow-up visit, there should be surveillance for mental health, and at every age, and also for the whole lifespan. And then we ask, did you receive surveillance for the following topics? And around 64% told us, I don't receive any surveillance for any topic. So not for the psychological ones, not for the social, and so on. And also we were interested in, when do you receive, if you receive surveillance, when is that? And most of the participants told us, it's only in crisis. So not on a regular basis, not what it should be, it's only really in crisis. And this is only, I think, part of the stigma around mental health. So we do have the evidence, but it's not implemented at all. The second part really was on information and knowledge about long-term psychosocial effects. And we really learned that around 63% were not informed about the possibility of psychosocial effects because of the treatment or the disease. So this is really many of them, and people told us they would have liked to have more information. So it's not that, because we often hear, oh, maybe if the children are too young, they don't want to hear. But over 86% told us we would have liked to know more. It would have been important for us to know. So there's insufficient knowledge and education about the long-term psychosocial effects. And also we looked at, when did this change maybe? So what you can see here, I know the figures, you don't have to see it, it's just the message we wanted to make. Of course, until around the 90s, we didn't talk about the psychosocial long-term effects in childhood and adolescent cancer at all. But as you can see, it's not perfect today. It's still too many telling us, I didn't know, I didn't hear about it. It was not addressed. So, we had really a list of, I would say, not so typical questions. So we really, in our consensus groups, discussed a lot, what are the daily life issues? So what are maybe you could also call it the subclinical topics, not the clinical depression or PTSD, but what is really important in daily life. So people really got on the social dimension, on the psychological dimension, and also on due to long-term physical effects, for example, and also independent factors of the disease. They got a list, and then they told us, you don't have to read this, I will guide you through it. Then people told us, was anything of this addressed? And did you have a need? So first of all, was the need, of course. We asked, did you have a need, for example, when adjusting to or building a new routine or concerning acute stress reaction? And if you compare this, we know from publications that, for example, anxiety disorders, in the publication you would read up to 27% of the survivors suffer from anxiety disorders. So this, of course, first of all, is too much, But this is only, as we said, disorders and the classification. And when we ask, did you have a need? Did you want to talk with anybody about it in a preventive way? 57% told us, yes, this was the case. For example, for increased anxiety and anxiety disorders. And you can see for almost, for many of the dimensions, it was over 50%. And then we ask, okay, you had the need, was it addressed? And then only 16% for the anxiety, for example, told us it was addressed in follow-up clinic, in an institution, or somewhere else. And then the next question was, did you get the offer of support? Yeah, did they offer anything to you? And only 24% of the participants told us, yes, I was supported. And then we found, okay, that's not really logical because more got the intervention, then it was addressed. So we had another look, we did another analysis, and then we found, and this is really dramatic, I think, the group who had a need and it was addressed was only 5.7%. And the group who had a need and got the intervention, this was only the case for 8%. So this is really the situation we have now. This is only the figure for the psychological dimension, and it's about the same for the social dimension and for all the other issues. So the need is a lot higher than we communicate about it, and also the support. It's important. This is what we found, and we really also discussed this a lot in focus groups in the project, in workshops and so on, that it's not only around disorders, it should really be about daily life issues. And here you can see, for example, for the social dimension, really the highest need was regarding to social relationships, isolation, financial problems, and so on. And also, 47% told us that they had already felt that their needs had been misunderstood. So this is another topic, and 18% had also been misdiagnosed. Yeah, so for this part, our key message would be that really mental health is more than the absence of mental disorders. This is what I think really, this is a very nice definition of the WHO. It's so important to have this continuum. And also this kind of drove us to develop awareness materials. If you want to, you can look them up. We developed pocket cards, and also there you can find the not so typical, I would say, topics. So for example, about communication, how to communicate, everything about the social dimension, also about educational support, about vocational support, also about, for example, the fine line between appropriate, healthy processing and emotional disorders. So, yeah, if you want to, just visit Beat Cancer EU, and you can also download the pocket cards. Yeah, and now I want to give the word back to Carina.
So, and I think just to allude to also our panel discussion, so moving forward, we need to ask ourselves questions. How can we break the taboo in talking about mental health? This is also something that I was a lot thinking about in the session before already. So when we assess quality of life, which questions do we ask? And then also who is involved in defining the questions that we ask? And then, on the more systemic level, how can we move towards health systems that really take into account the whole picture and not only physical health? And then, lastly, we were talking about prevention. How can we change our health systems towards prevention so we can prevent fires instead of extinguishing them? Thank you very much.
And we will call the third panelist who's going to join us. She's there, Susanna Tomasikova. Good afternoon, Susanna, and I will introduce you to the audience. You're the head of the Survivorship Competence Center at Childhood Cancer Switzerland, and you're also a member of the Childhood Cancer International, so the CCI Europe Committee. You are also one of these survivors and an active patient advocate. I would like to thank you because I know that you are used to tell your story, but though this is amazing for us to have these testimonials, to start this discussion, because it is true that it is not easy for people who didn't went through this, to understand really what a child or a teenager has to cope with, and then an adult also, because this is like an imprint that will stay with you for the rest of your life. That's being said, I would like also to invite you all in the room, patients, parents of patients, family of patients, friends of patients, to share your experience and also, you know, to share your professional expertise if you have one in this field. But I think that really from this morning, that's what we have seen. When we put in common, we have much more answers and maybe some also points of discussions that can emerge afterwards. So I will start with you, Ulrike Leijs. What we will address, and you already talked about it, this is quality of life of survivors. What does exactly the concept encompass, sorry?
Yeah, so you're right, of course, a little bit, I mentioned this before, but I think the important thing is that we really have this biopsychosocial perspective. So it's not only about the physical well-being and resilience, it's really more about freedom from anxiety, depression, also freedom from social isolation, also socio-economic burden. So we have discussed this a lot, and this really also plays a huge role in our community. And then our goal is always really looking at participation in life. And of course, age appropriate for children and adolescents. So yeah, it's also a part about participation in party, for example, as you mentioned, and school and career development and so on. So we really try to look at activities, participation, more than disorders. And one thing what was really very often in our discussions is really that quality of life always has to be individual and subjective. So it's always what you perceive, what your quality of life is, and this can be so different in many different contexts and depends on so many factors. And like quality of life from outside can look similar maybe, but it can be perceived so differently, and this is really, you have to have a look at all those factors and then you should decide. And this very often people forget about this.
Susanna Tomasikova, which are the factors, actually, sorry, yes, I will give one to each of you. Thank you. Distribution. There you are. And so which are the factors influencing quality of life?
I mean, we heard today already many of it, and one main part is starting with the health, with the mental and physical health. And as you already heard, in our population, within the survivors, there might be already challenges due to the treatment, due to the diagnosis itself, and coping with it. It's already one way you have to learn on the way, which might be much more difficult if you, first of all, has not been informed that something might come up, that you have no awareness, and also when you have the feeling you are on your own. Especially when it comes to the late effects, I mean, hopefully we have the impression it's improving, and those patients who are now, the topic is popping up more and more, but there are a lot of people out there who has been treated in the 60s, 70s, 80s, who has never been informed. They were just gratulated at the end of the treatment and saying, okay, you are healthy, go ahead. And just realizing that finishing the treatment, it's not you are healthy, and then what might come later, and that it's not your fault or not fault of your body, and realizing you are not alone with it, already makes a huge difference. So that I would say, okay, the one thing is really the knowledge, the awareness, then also the connection to the peers. I mean, we are talking about a rare cancer, and we are talking about childhood cancer, but it's not just one disease. It's at least 60 different diseases, and still rare, and some of them super rare. So even in my case, like three cases per million. So meeting someone who might have experienced the same is pretty improbable just in your daily life. And then really meeting someone, thanks to the communities, and realizing that the issues you are facing are nothing, let's put it a bit strange way, nothing special, that you are actually normal in that way you are feeling or dealing, it's already a huge access. And of course, just to finish what already has been said, realizing that you might have issues, finding a community who understands is just one part of the story. If there is no infrastructure who can help and support, so talking about long-term follow-up structures, also including the mental health or vocational support and so on, won't help you. I mean, you can do a lot with individual resilience within the community, but if there is indeed a medical issue and there is no specialists who are looking at it, or you are not taken seriously because you are still too young to have cardiovascular diseases, then we might have a problem.
What was the most difficult for you as a child, and then I mean as a teenager, and then after as a survivor?
Well, I was diagnosed with 19, so I can't talk about the child perspective. And I was quite lucky to be diagnosed in one of the best centers in Europe, which indeed offered a peer support. So I was introduced to the community already during my treatment. So for me, there was already basically the place to went to. Nevertheless, seeing the struggles within my family, what this kind of diagnosis case to, and especially after the end of treatment, when I thought, okay, now everything's going back to be normal, and realizing that now my family has having troubles after this surviving mode, was pretty harsh. But thanks to the community I was at from the very beginning, and I could really express myself without being politically correct or taking too much, let's say, too much care of what my family can think of or what might they be concerned of if I express myself. This was really helpful. But being involved,
guilty, that's
not really guilty, but
or avoiding actually to feeling guilty when you have to say something. What you said is, you have this chance. Why would you finally come with this kind of problems? Okay, you're unhappy. Okay, you lost half a year of your life, but you're alive. And isn't there? Wasn't it something that you found out in this in this survey? This feeling of the children of wanting to be normal again for their parents also, because they see their parents suffering? Or is it something that doesn't happen?
If I mean...
Yes, sure.
I mean, that's for sure one part, but there are many others. Also expressing, having a fear of getting sick once again. This is something what I do not discuss with my family, because I feel I have to protect them, but I'm fully open and I know that my survivors' peers will handle that. So even those, when there are some results coming which might be a bit struggling, it's first my community, maybe not the whole community, but few people out of the community I know I can rely on, I can kind of digest before I talk to my family. So, but they might be different, so it's not just the guilt, it might be also the anxiety, but some others depending where you stand and how close is your relationship with your family and so on. So
these are really accountable people that you can go and ask questions or maybe be crying in front of. which is also sometimes important, I think. Okay, so what you did here is that you made evolve the definitions, because you had a definition, a standard definition of quality of life, but going to ask the patients to be here from the beginning, that is something new in the methodology. Is it, Karina?
Yeah, it is. So I would really, so we are talking, there is a term that's called patient and public involvement in research, and this is something emerging. So they are doing this quite well in the UK, continental Europe, not so much yet, but we are going there. And so I think to the extent that we did it in EU4Health, it was really a novel approach. Mm-hmm. Coming from exactly this, so because we, as organization, as CCI Europe, we have been collaborating with academia for many years, and there's often discussions, and this is also the reason why patient experts, and I'm looking again here at Delphine, and also Hannah in another project that we were part of, why we are at the table, because also researchers see that we bring different perspectives into the project, into the research question. It's still then always the question how much of it is implemented in the end. And so having really this project driven by patients' needs was quite novel, yeah.
Mm-hmm. There were some findings also in this survey. Patients, for example, they report things, problems they have on social networks, on forums. They do not report these problems to doctors because they know that this won't be addressed in the same way. They do not, not all the time, but often they don't report their problems. That's something that you saw?
Yes. Yeah, and so this again from a rather personal testimony. So there is patients and also parents do report things to their doctors, but often they are not taken seriously, as Susanna said, or they are not in the context of this consultation relevant oncologically, or they just don't know. Mm-hmm. And then, yes, sure, there also are things that are not reported, but also why. So when I think back to myself, so I was then 17, 18, 19, and there are so many things that are also that have to do with a lot of, like being ashamed of certain things. So like, for instance, the hot flashes, also I didn't know actually what it was, but in the end, it was related to my ovaries not functioning properly anymore. I did not address to them, hey, I didn't have my period since end of treatment. But also they didn't ask.
Ah, yes, they didn't ask.
They didn't ask, and I didn't bring it up because also I thought, well, if this was relevant, they would ask. So it is this thing of things that you do tell them, like having pain a lot every day. Oh yeah, well, we did an X-ray, there is nothing. Deal with it, take, like your ibuprofen or whatever helps you. These things are addressed, some things are not.
Yes. Is there anyone in the audience that would like to participate or to be involved in the debate at this stage, or to share something, an experience? Nothing at the moment? Yes, I see someone there. But you need a microphone. Ah, yes. You also want a microphone, Caroline. One for you. Yes, sure. Peter Falkay.
Thanks. Yes, I have to say I'm really ashamed because it should be our job to help you. But I have to say that there is a problem from psychiatry to find people. I was fighting for roughly 4 years to find someone, a senior physician, who would build up a service like that. And it was interesting to see why that is not happening. And I think maybe we should liaise on that and, do more promotion, because a lot of people don't know that, what I was listening to. To be honest, I knew some of that, but not all of that, what you referred to. because I think for young people it would be very interesting, because they are educated well, so they should recognize, you know, your complaints, and you know, and could be able actually to differentiate what is now real illness or what is, you know, complaints, but should be taken seriously because they were educated that way. That is just a remark. But I have a question. I mean, what we speak about is stigma, right? I mean, but you know, we're living with that quite comfortably. But my question is, what do you think could be done from your perspective? I have a philosophy on that, but what could be done in order to overcome, you know, this idea that, you know, mental illness does not exist, and if it exists, it has something to do with discipline, full stop. So, any ideas?
Anyone?
Yeah, I mean, this is really the most difficult question now, and I really agree so much 100%, because this is so much about communication and stigma, and it's also really, we have to admit, being a healthcare professional, it's not so easy also for the healthcare professionals to break the stigma and to ask and to talk about the mental health issues, because then as a healthcare professional, it might be that you feel helpless and then you avoid it. It's really, it's not the normal thing to talk about it. And so, what we, for example, also maybe this can be a little solution. What we did in our team, we really have in our follow-up clinic all the disciplines in the room. So there is the social worker, psychologist, and of course physician for the late effects. And then maybe at the first follow-up care visit, the family thinks, oh, what happens? Why is the psychologist sitting here? Yeah, because also the family has the stigma, and as you mentioned, it's not so easy to talk about it and to tell about your mental health issues. But then we tell them, okay, the late effects are biopsychosocial. This is because of the treatment and the disease and so on. So it's the normal thing to have the team biopsychosocial. And then this is really a relief for the families, because then they think, okay, it's okay to tell them because they want to listen, they're here for it. And this really, in this small bubble, kind of breaks the stigma, because it's not anymore a shock that the psychologist is here and that people think, oh, she's here, and then I will hear about maybe a relapse. Yeah, it's the normal thing, and people prepare. And we tell them, please tell us everything, because we need to know, otherwise we cannot support. But I know at the same time this is only a small step.
And what I'm stressing, you see that only a subgroup will develop, you know, complaints. So, you know, this is normal, but, you know, this is stress associated. So the way I always enter is I say, look, you had a lot of stress with your illness, and that is due that you now have sleeping problems, anxiety, and things like that. Can I help you there? And that sort of introduction is most helpful, because if they realize I'm a psychiatrist, they say, oh God, you know, I'm fallen, you know, I'm just, you know, I'm lost. And I say, you're not lost. It's something very normal that under stress, people will, you know, have sleeping problems, anxiety, and things like that. So that's an avenue how I try to bridge in. Doesn't work out always, but often. Okay, thank you.
Yes, go ahead.
I have two small things. So first of all, I hope we do not bring up the impression it's like us or them. So basically what we wanted to show off is like involving patient advocates and the experience together with healthcare professionals, how it can help, and maybe partially answer to your question. So what we wanted, and also hopefully are already seeing that we are achieving within the project, was improving also the empowerment of our former patient or survivors, really having checking links and saying, okay, it's okay that you address this. Feel free, ask if you haven't understood. So it's not just that we expect that healthcare professional will cover everything, but also encourage, so informing, making awareness on our side within the community, and also letting the people know what might be the issues and what they can ask for. So that's definitely main part, because just being there and saying, okay, I'm the victim, and now expecting that everything will be fine won't work. And very last, and I let you, so when talking about the experiences, maybe from Karina and myself, we know each other almost for 20 years. So basically we experience the diagnosis and the treatment 20 years ago, and we had kind of this dynamics group regionally also, where we said, okay, we are the first generation on survivors where we can start to complain and saying, okay, it's not just the survival, it's about the quality of life, what we need more, and not just saying, okay, that's it. So I think the things are developing in a good way, but we still should try to continue, because saying this is not enough, we are not there yet. Yeah.
You said we are the first generation. Maybe I will come back to you with this question. Are social medias also a way to get involved with other patients, to enter this community, though you do not have the support at the hospital, for example? Is it a reason why maybe things are evolving?
So, I mean, I would say so also. I mean, knowing the two of us, just looking here. So, so this is not yet our generation. So when I was under treatment, Facebook wasn't even a thing yet. So we didn't even have Wi-Fi in the hotel rooms.
The hotel?
No, in the hospital room. Okay, no, but yes, absolutely, it is, and we see that also in EU4Health with the virtual platform that we have been building. So many young people are finding us and using this platform, and are really finally I can be here and exchange with others from all around the world. So this does help, yeah.
Yeah. Beyond health budget, because I think that's a problem that we have been addressing before, that we will address even another day. Beyond health budget that you could claim for, isn't it necessary now to have a special field dedicated to this survivorship, like dedicated specialized psychologists, psychiatrists, practitioners, nurses? How would you build it, actually?
You mean now? So just so I understand your question. So how would we build it? If we had the resources?
Yes, if you had the resources, of course, dream big. I mean, dream big always, out of the box.
Yeah, it would be multi-professional. It would be integrated in the big whole, big picture.
What would you need? Big centers where you can go after surviving, or teams that would be involved from the early beginning of the disease? Because one day you will, I mean, if you are lucky, survive. So how would it be created to be the most effective?
It's also a tough question, I would say.
So sometimes I have naive questions, sometimes I have good questions. I'm sorry.
Now, so I'm just, but maybe we can, just look at this together. So, because I'm thinking also transition. So we are looking at pediatric oncology. Delphine mentioned this in her opening remarks, transition. So you have pediatric oncology with pediatricians. So the healthcare professionals involved here are pediatricians, also from the psychosocial side and so on. And they are allowed to treat only up to the patient is an adult, because then it's the adult doctors who are in charge. So I would ask the question, is there even, a center or a team that could accompany you throughout the whole legally? So how do we facilitate transition to adult healthcare? And how do we make sure that in the adult healthcare system we find enough colleagues who are interested enough, to put it again in a rather nasty way, to take care of this population?
And I think there are so specific needs we have there And we do have some of the first, I would say, long-term adult follow-up clinics. And what we have learned is that, first of all, you would think, and also society and the health system would think, okay, you need the traditional groups of healthcare professionals. And then it's us to say, okay, but we do know that, for example, for brain tumor survivors in childhood and adolescence, we do need neuropsych follow-up lifelong because of this and this and that. And we have so much evidence on this. So then it's on us to really fight for example, being a neuropsychologist there. And this is, of course, not the easy part, but this is possible. And then you have the team really specialized for the late effects. Yeah.
And if I may continue, I have 2 points.
Yeah.
Which is rather on the low financial part, I would say, and repeating peer community. So when we are not talking about like really having an issue where a professional support is needed, it sounds so simple, but really finding a community and having the possibility to exchange, or not even to exchange, just to listen to. You don't need to actively participate. And being there might already help. But to your question with regards to long-term follow-up and how it could be or should be organized, it's an answer of non-answering. Sometimes I have troubles because there is no the survivor and there is no the perfect model. I mean, we are all as a people here around different, and with the different needs and the different challenges, there might be survivors who are super happy to coordinate it on its own and go every 2 years and managing it there. And there are survivors who need much more support. And we should really put the support to the as less as possible, but those two people who really need it. So, for example, if I coordinate it myself, I don't need to be called every 3 weeks if I manage to. But some other people might appreciate. So really having a palette so you can really go for the best option which fits maybe even phase of your life at that point.
Yes.
And especially if, I mean, the late effects won't be less with the time, there might be more support needed at later point. Yeah.
I think we had a question somewhere.
Yes, it's actually a contribution. So what we see here is a clear example of not having an EU health union for so many years. So I'm very happy that we are here breaching walls. I'm from the 1,400, I represent ESPA, the European Federation of the 1,400 medical spas. In many European countries, we have medical spas as our hospitals, but we just emerged there where there is hot thermal water coming out of the ground, and that smelly water or that very colored water, there is ions and oligo elements, and you push that straight through the skin into the body. And that's how you can reboot the immune system when, for example, after the second chemotherapy, your complete gut biome is completely messed up. You're vomiting, you have diarrhea, and so forth. In France, for example, or in Germany as well, the Deutscher Heilbaderverband, all the women who have cancer, they are all put in a bus. I'm speaking a little bit heuristically, but it is more or less like that. They are all put in a bus, and they're all sent, and it's paid back by the French health insurance system. And it's like that as well in many other countries. And they are being sent to dedicated medical spas where these women are received by women who have already have been there already for 2 weeks, their hair is growing back and so forth. And it's really women helping women going through and revalidating there. So this exists in many countries. It's just that we don't know this because there was no Director General of Health helping us to coordinate and share all this knowledge. So this knowledge is now here with broken through the silos and so forth. We are also sponsoring the pediatric cancer as well. So normally your French colleagues, for example, or German ones, they should be able to inform you about all this. Thank you.
And then you need the social security to say yes for the parents, which is
just
something
a very
else.
short remark.
Yes, Peter.
If you want to have a mental health specialist to actually, be in the team, you need to have that by law. I give you an example. We had for a long time, in transplantation medicine, a lot of people, they fell out of it or discontinued, for instance, their medication, which is needed, so then they lost their organ. So then in the German system, there was by law, everyone who is now transplanted with his heart, kidney, whatsoever, needs to have an opinion by a psychiatrist. That pushed us into very much, because we have to do that sometimes overnight and things like that. But I think it reduced significantly the amount of people who then actually had problems due to mental health problems. So if you want to really, because, all the things with stigma, and so, that is getting better. But if you want to really have a step, that would be my recommendation. Try via politics and get it so it's mandatory, it's not facultative.
Yep.
Can I quickly add something? Of course, everybody here is welcome to come to me, and I will organize in your countries with your groups visits to dedicated medical spas for children who have cancer, post-cancer revalidation for children, and post-cancer revalidation for women. Just come to me and we'll set it up.
Okay, I think we have a networking time for that, so we'll talk about that after. Thank you. Yes.
May I comment to?
Of course. Of course.
To the about having this by law. So I completely agree. So I could not agree more. And if we look at, we have Europe's Beating Cancer Plan. So then we look at the country level, and so there are people who know more about that than I do, but we see that not every country has a national cancer plan. So in Austria, for instance, we don't have a national cancer plan, we have a framework, so that's more like a recommendation. So we can stick to it or not. Sometimes rather not than yes, and so these things, yes, need to be also in here. And then I would, again, it links again, I think, to the stigma question also, and how we approach this topic on a systemic level. And if we look COVID, so all of a sudden, mental health was a very, very big thing, and I think in that period, the stigma or the taboo was a little less for a whole society, for the whole world, basically, because all of a sudden, mental health affected everyone, and not just the special few, like the crazy cat lady. Also, how do we talk about mental health issues, for instance? So I think we need to exactly destigmatize already by education in school, the ways how do we approach, which language do we use, for instance, and to make sure we don't have to always cope and just push through every negative emotion that we have, but also learn how to speak openly about that. And I think this is something that we need to tackle as a society, so that it will be also easier to put these things in legislation, so that there is just no question that any ward that treats children with cancer or in follow-up care has X number of psychosocial professionals paid by the healthcare system.
We are talking about daily life, and there is something that is really important, and you experienced this. You were young, and then you had to go back to school, then to the university, if you want. That's not necessarily the path that everyone will follow. But then at a moment, you will also need to find a job. That's what you are expected to do. So what you saw in this survey was that there was a little help, very few help for that.
Yeah, unfortunately, that's true.
And what kind of help actually did they receive?
Because we would know also there are guidelines actually that tell us what we would need. For example, this really specialized person who is equipped with all the knowledge about neuropsych and also the, for example, the neuro-oncology, pediatric knowledge, and then coordinates the communication between the schools and the clinic and the family. So this is really would be the recommendation in the guideline. But reality is that in many countries, these positions are third-party funded, for example. And this is really, but this is another good example for also the legal options. We really fight for this, to get these positions in the hospitals, because this is true for education and career support. And we really, this should be, it's a little bit getting better in the educational systems, because there are things like, for example, disadvantaged compensation written in the school law, and then you have to translate it to the teachers and really to work together to communicate what is really needed for this child. For example, a child really with above average abilities, but having problems in, I don't know, divided attention. It's really a focus problem. Yeah, and then we talk to teachers, and then this is a legal option to have this compensation. But of course, people have to know, and there's so much work to do regarding career support, and this is really what we found. And it's not enough also to ask one time about it in follow-up clinic. We, of course, because adolescents are developing, and and we have to continue to address the topic, because this is really daily life for children and adolescents. Yeah, it is education and then, career. Yeah.
Would anyone like to give us some insight on this? Anyone has to share a testimonial? Yes, maybe Delphine? Caroline.
Thank you so much. So my son was diagnosed at the age of 9 and then relapsed when he was 11, and there was a stark difference for him in terms of sociability when he went back to school. Much easier when he was 9 for several reasons. First of all, there is one single teacher overlooking the pupils, and so bonding is created in the class and it's easier, and then children don't judge as much each other. But when he came back when he was 13, it was a disaster, because his physical appearance was really odd. Because of the treatment, he was gaining and losing weight every other month. So he looked fat or skinny. His hair was growing, falling, regrowing weirdly. So he looked like a weirdo, which wasn't easy. And it's also an age where children understand what life-threatening diseases mean, which they don't really understand when they're 9. And so you project death as a child in the classroom. And so he was definitely harassed because of that, because he looked weird, because people were afraid of death. And there is no, to my knowledge, country organizing a good program, go back to school, or whatever. Have you ever heard of best practices in certain countries?
You mean someone teaching, helping the class also to get this child back and involved in the class?
Yes.
Yeah, I mean, we, in the EU4Health, we had also trained a trainer for education and career support, and what we did there, for example, is to really exchange about best practice examples in the different countries, and there are really few. And then we also decided, because in some countries we have legal options for support, and this is also really important because the schools need the staff. They need really the very educated teachers. Yeah, this is what we really learned is the general support very often provided. This is not sustainable. This does not work. It really has to be people knowing about the specific late effects and the situation, for example. Yeah, but yeah, this was a big part. We had one work package on the education and career support, because this is really dramatic, and it decides over the lifespan, what the child and adolescent will do. Yeah.
Did you already have a chance to talk to politics about this topic?
Going back to school, no, not specifically yet. We're currently running a project on the topic.
Mm-hmm. Yeah, very interesting, because it might change the future of these young adults, I mean children and teenagers. Mm-hmm. Is there anything that we should be aware of when a child becomes sick, gets sick? Is there anything that parents should know, or that teachers also should know, to secure, I would say, the future of this child? That will, in the end, you said 20% of the children, unfortunately and really sadly, will not make it. But for the rest of the people, the rest of the children, they will come back to the class. They will go back. They have a lot of stuff that they will have to build. And is it only, I mean, the follow-up care is only necessary for the children, or for all the people, all the support team that has to be created around? You can go on, the three of us, the three of you, sorry.
Go on, it's just a very short comment from my side. It's so important really for everybody. Of course, as you said, it's a family, and the whole surrounding has to get education and the information. It's really, and also the care. Yeah, it's really important. And also people have to realize that this is not what we have in our minds. It's very often what children tell us. To be sick is like 1 week and then it's over. And so sometimes in the hospital, other children tell us, or no, the other way around, the children in the classroom tell, oh, we saw that boy having ice cream. So he's lying, he's not sick. Because this is what we have, there's disease, and then like maybe it's a few months, but then it's over. And this is not the case. And this is, I mean, for children we can understand, but also teachers sometimes tell us, you see now it's like 4 years ago, now everything has to be fine.
Yes.
And we really cannot do this disadvantage compensation now, but this is not the case. Yeah, because it's in the course of development, and we have to realize that support has to be ongoing.
And how long should this support last for, actually? Because we are talking about, what, the first years after cancer? Are we talking about someone who was sick when he was young, and still at 40 or 50 he would need some help? Because there are steps in life. I don't know if you, I mean, each child evolves with steps, and it should be the same also for the patients or ex-patients. So how long does this last? Do you have any idea?
So in general, for follow-up care, lifelong. Because also then, you know, as you, so yeah, now I don't want to cite anything wrong now, but also, you know, you have your late effects maybe already, you know, now we are in our mid-30s, for instance, and then, you know, it can also aggravate. So we all know that the older we get, the more prone we are to medical issues, etc. And things can come up. So, I mean, we just, you know, new research is emerging about very, very, very late effects. Then also having secondary cancers, for instance, so lifelong and whenever accessible. So I think this is the point. It needs to be accessible, lifelong, for you know, physical, medical follow-up care, but also psychosocial follow-up care. Because here we have exactly what you know, we all have phases and different steps, moments in our lives. So talking about family planning and fertility may not be very relevant for a survivor 16 years of age, who has been treated a couple of years before. But then it might be very relevant maybe 15, 20 years later. So, and then this is where support need comes in.
So if I understand well, we are at the beginning of this discipline, and we need to evolve, and even a lot. So there is a lot to do. Does anyone have a question to finish? Yes? So a question, not...
In Europe, we have the EU policy for athletes from sports, dance, acrobats, tactical athletes, and the social capital of athletes. So they are normally all sensibilized, and they know that they have a social role to play. You can call upon them. Is it difficult to reach them? And then secondly, also all the children and the youth TV channels and animators, they all know about their social role as well. And sometimes they also come to schools. We have the Beat Bullying program. I think in every country we have such anti-bullying programs, and you can call upon these people. Is it difficult for you? If there are only so many kids who have cancer, is it then so difficult to reach and to find these heroes, these local heroes, to come to them in the class and support them? Thank you.
But don't you think that the parents maybe should be at the beginning of the story, because maybe they do not request this help? Because these people, of course, if you call them, I think they will come. Some singers, football players, they are deeply involved, but does anyone request that? I
don't think it makes sense.
No? So maybe can she have a...
If I can come back to my personal
Yeah,
experience
sure.
of bullying, which I can also relate to the experience of several other survivors, because we had workshops on bullying in school. I don't think you need a soccer player to come in school to help out those kids. I think you really need to have trainings on empathy, on diversity, on things like we are all different and it's okay, and each of us is. It's really an age where every child is struggling with something, and it's really about being open about the fact that we're not all super strong, and that we all have a weakness that we have to overcome, and the best way to overcome it is not by bullying others, but by being truthful on that. And so if I can explain what happened in my son's class, we ended up inviting, there is a psychosocial authority in every school. They ended up reaching out to psychologists who organized a workshop on differences, and it really brought everything down and made it better, because many other children were actually unhappy alongside my son. But it's not about a rock star.
So I think that about all we heard, yes, go ahead. Yes,
Again,
sure.
to comment.
Of course.
And what you just mentioned, I mean, the CCI International, but also in Europe, the parents' organization have many initiatives. I mean, even in Switzerland, we have like a doctor and psychologists are going to the school and explaining what's going on, what's going to happen when the kid is sick, and so on. That's the one point. So there are already a couple of things which are working, and that's how the, let's say, the international community also works, that we share the best practices within our get-togethers, within our conferences. But a small comment on what you mentioned with regards to the school having a pop star or hero. I recall there is, I would say, a wave of ongoing discussions also within the community. There have been projects where, for example, in Austria, we said, okay, we go to the highest mountain to show off that survivors can do after they manage to get through the disease, they managed everything. And it was so controversial within our community, because yes, some of them might still able to go to Großglockner or to, let's say, Matterhorn or whatever, but there are a lot of people whose reality is changed differently, and they Matterhorn or whatever might be independent life, or finding a job, or not even job which is paid, but participating in a society. So it's sometimes be tricky. Of course, you get the attention from the broad public, but you have to really be careful what is your message, because then when your community is not fully convinced with the message, it might backfire quite fast.
Thank you. Thank you for the three of us, and thank you all also for participating to this debate. May we have a look, Monsieur Lapin, at the design? Because we want to see it. Whoa. Hey guys, you look like in a comic, huh? Just so this is what we will have to remember from this session. And actually, Monsieur Lapin, as I said, is drawing, but I know someone else who will have other conclusions and another summary of the topics of the day, and I will call Professor Michel Goldman. Thank you. Thank you so much. And so, Michel, what do we have to remember from this day? I heard a lot of things, but one point just that I will remember is data. I don't know what was your impression on this day, and so we will listen to you.
Yeah, before I answer your question, I would really like to warmly thank all the speakers and yourself, Vanessa, for moderating this conference. I know that for everyone it means a lot of preparation. And really, thank you very much for demonstrating that indeed we need experts from different disciplines to address the important challenges that we discussed today. Of course, I would also to thank warmly the people from my team who was in charge of the organization of this conference and of the other events that will follow during the months to come. And she was already mentioned, but Caroline Van Swieten did really an incredible job. I would also like to mention Naomi Friedlander and the other the other members of the I3H team, especially the PhD students. I will not mention them all. Hilda Stevens is smiling, that's nice. And I would also like to thank Palina Shoshuk from the Solvay Business School in Brussels, at ULB, as well, because I must say that she was the one who convinced me that we should go and to apply for this competitive call. And I would also like to thank Rachel Leproux. I don't know where she is, but she's from the research administration at the ULB. And I can tell you that to organize such a conference with 4 different partners is a real challenge, also dealing with negotiation with the Commission. And Rachel, you have been really so nice in really bridging all the partners of this consortium. Then, as I said, we had several partners, several organizations, the One Sustainable Health for All, and Casimiro Visini from this organization helped us a lot to design the first session. For the European Brain Council, I would like to thank Christine Arts, who also helped us a lot, and for Childhood Cancer International and Axel. Now, so I hope that I didn't forget anyone, but really my warmest thanks to all of those who made this event possible. Now, coming back to your question, Vanessa, I agree with you. Data are central. And I think when we think about, bridging all these topics, we heard several times, including in the last session, about the importance of data collection, of data management, on the way we handle data, and especially big data with the use of artificial intelligence. And we understood that there are some limitations, but still AI is everywhere those days. And also we heard that it's essential that those data are used, interpreted for the common good. We are there indeed to make sure, also with adequate ethical rules, we have to make sure that the data indeed are there for everyone, to help each patient, each caregiver, or our societies. Now, it's true that during this conference we learn a lot on how to build the future of healthcare, taking into account the complexity of non-communicable disease, which were addressed today, and the multiple factors contributing to brain health and the quality of life of childhood cancer survivors. I will come to that in a moment. This morning it was stressed that environmental changes have a strong influence on the development of non-communicable disorders. Climate changes, air pollution, various types of disasters should certainly be addressed as first priority to improve global health of all our population. We also realize that several non-communicable diseases developing in late life can be efficiently prevented by simple measures that should be implemented early in life. And in order to efficiently implement those preventive measures, it is essential to improve what I would call health literacy. Education was the other important word that we heard several times during this conference. And I would talk about health literacy, which means the basic knowledge on the determinants of health in the general population. And we indeed should start at school to educate our children about the basis of health literacy. Regarding brain health, we learned that to reduce the societal and economic impacts of mental disorders, we need to get a deeper insight into the brain circuitry, the brain connectomics, in order to understand the influence of multiple events occurring during the life course on the development of various diseases. We mentioned depression and dementia. What will also be important is to define clusters of patients who share common features and might benefit from tailored therapies. The overall challenge here is to apply the principle of precision medicine, which was pioneered in oncology, to brain disorders. Because of the extreme complexity of the brain and the multiple factors which can affect its function, novel technologies, again data science, and artificial intelligence with its limitation, will be essential to apply the right strategy to the right patient at the right time. Finally, I think that this session on the quality of life of childhood cancer survivors emphasized the need to go well beyond the development of new sophisticated target therapy and to assess and address the short-term and long-term impact of these therapies on the quality of life of cancer survivors. These will need the involvement, I would say the empowerment of patients and their caregiver. And I think that this last session clearly illustrates the importance to have patients and patients' organization deeply involved in the design of research and innovation, but also in the design of new policy to really make sure that we address their needs. So we hope that the topics that were addressed during this session and the main messages that were emphasized will hopefully be considered in the elaboration of the new Research and Innovation Framework Program of the European Commission, which is announced to be transformative. Some of us are quite skeptical based on our experience, for example, on the Horizon program, but I think that now we have a unique opportunity. And to tell the Commission you want to be transformative, fine. For this, you have really to be much more interdisciplinary, and you have to give much more power to patients in the design of your programs. And really, we hope that by supporting interdisciplinary approach and involving patient representatives, the new project will foster the translation of basic knowledge into innovative solutions for the benefit of affected individuals and the society at large. The One Susceptible Health for All, the European Brain Council, and as we just heard, Childhood Cancer International, will be natural partners for this new project launched by the European Commission. Thank you so much for your attention and for staying with us until the end of the conference. Thank you.
And congratulations to you also, because you, of course, mentioned everyone, but congratulations to you, because you made a lot for this conference to happen. Thank you so much for having joined us all the day long. Thank you to all who are watching us on the web. It is also important to think about the fact that you were here also with us. Too bad for you, since you are not here, you cannot actually participate to the end of the day, which is actually a network session that we will have around the drink. That's also important, around the drink, in the Marble Gallery, so first floor. Thank you all for this.